Welcome to our two-part presentation on the role of polyenylphosphatidylcholine, which we will abbreviate as PPC, in the prevention and treatment of cardiovascular disease and within the broader field of integrative medicine. My name is James Roberts. I've been practicing medicine for 33 years, hoping someday to get it right. But one of the right things that I have been doing over the past 25 years is to offer my patients polyenylphosphatidylcholine within a comprehensive and integrative approach to their individual health challenges. With respect to my training and background, I'm board certified and university trained in internal medicine and invasive cardiology, and I'm a fellow of the American College of Cardiology. I've done thousands of heart catheterizations and invasive procedures. I've also completed the coursework and passed the written exams in chelation therapy, oxidative medicine, and bariatric medicine, and I'm an advanced fellow in anti-aging and regenerative medicine. I spend a considerable amount of time teaching, primarily the principles of integrative cardiology, but also nutrigenomics, which we're going to touch on, and heavy metal and organic pollutant detoxification within various integrative medicine training programs. My practice is also involved in research, new drugs that fill a need, new nutraceutical approaches, and new devices such as external counterpulsation and static magnetic field therapy. Our practice randomized more patients into the trial to assess chelation therapy than did any other cardiology program in the United States. And of that statistic, I'm particularly proud. I'm also the co-author, along with my colleague and good friend Stephen Sinatra, of Reverse Heart Disease Now, a patient manual of integrative cardiology. This book is now 11 years old, and our science has changed, but our philosophy is not. Steve and I have followed similar career trajectories. As younger physicians, we spent all of our time in the hospital, caring for patients in crisis with heart attack, unstable angina, arrhythmia, and heart failure, doing invasive procedures, often over and over again, on the same people. One of Steve's patients with refractory heart failure asked if he could try this new substance, this coenzyme Q10. Steve had never heard of coenzyme Q10. His professors didn't tell him about coenzyme Q10, but this patient was deteriorating. Steve was out of ideas, so of course he said, yes, give coenzyme Q10 a try. The patient got better, as did other patients. Steve went to the literature and learned all he could about coenzyme Q and saw that there were clinical trials supporting its use, clinical trials that none of us were exposed to in medical school. Fast forward a few years, and Steve became the leader in the field of metabolic cardiology, the use of coenzyme Q, carnitine, magnesium, ribose, and other substances in the treatment of cardiovascular disease. And I'll refer you to one of Steve's many books, The Sinatra Solution. Now, if you're my personal patient, you're going to find this difficult to believe based upon my current behavior, but in my mid-30s, I was tied with two older doctors as the leading emitter of cardiology patients to my 800-bed hospital. Most of my admits were through the emergency room, heart attack and heart failure patients at the request of their primary physicians. Our CCU had 8 beds, and one Tuesday afternoon, over a 2-hour period, roughly 25 years ago, all 8 charts had blue stickers on them, indicating that this individual was a Roberts patient. That was a very long day. What happened to me, I was becoming frustrated with what I was beginning to recognize as a revolving door approach to cardiovascular medicine. We'd stay up all night helping a patient get through a crisis, they'd go home, and then they'd come back with a recurrent problem because we were not carrying out any preventative actions. We didn't know any preventative action. We were taught to manage crises and do procedures. I had this 180-year-old lady who came with a small heart attack. I did her heart cath, found 3-vessel coronary disease, told her she needed bypass surgery. She demurred. She didn't want to undergo bypass surgery. So I told her that she would die if she didn't undergo bypass surgery before she left the hospital. I actually said that, and I actually believed that. She went home on meds, and I'd see her in the office and tell her that she was going to die if she didn't undergo bypass surgery. I prescribed more meds, but I didn't think she was really taking them. 2 years into this, I was getting ready to tell her that she was going to die without bypass surgery when it dawned on me that she was not dead and that she seemed to be doing pretty well. I told her this and she blurted out that she'd been receiving chelation therapy. Chelation therapy, I shouted, that doesn't work. But Dr. Roberts, you just said that I was doing well, even though you told me 2 years ago that I was going to die without bypass surgery. Oh, it turns out that a number of my patients were undergoing chelation therapy behind my back, and they were all doing well. This was upsetting. My professors had told me that chelation therapy was this dangerous and ineffective treatment, but the patients were obviously benefiting. So I called up the doctor who was treating them, Terry Chappell of Bluffton, Ohio, a real leader in the field of integrative medicine. Terry is the past president of the American College of Integrative Medicine and the International College of Integrative Medicine, and like myself, a principal investigator in the trial to assess chelation therapy. And I asked him 25 years ago how this chelation therapy could possibly work. Dr. Chappell related that heavy metals were a cause of oxidative stress, and that oxidative stress was altering cholesterol, leading to its deposition with the arteries as plaque, which is 100% correct. We now all know this, but I didn't learn about lipid oxidation from my professors or invasive cardiology colleagues. I learned about this from Terry Chappell. Well, I quit trashing chelation therapy, and when patients brought it up, I referred them to Dr. Chappell. I didn't get involved myself. I knew it was a good idea, but at that time, I did not have the personal strength. Then I had a patient who was dying while awaiting a heart transplant. Her bypass grafts had shut down and her angioplasty sites had closed. She was in severe pain. The only hope was cardiac transplantation. Now, those days you had to wait 3 to 6 months for a heart transplant, and this patient was doing poorly with chest pain throughout the day. She was going to die. She wasn't going to make it. She brought up chelation, and I told her about Dr. Chappell, but she wasn't stable enough for the 1-hour drive to Bluffton, so she told me that I had to do it. Well, I didn't want to do it. I hadn't at that time been trained in chelation therapy, and quite frankly, I didn't want to get involved. I knew that if I got involved in chelation therapy, that this would meet with the severe disapproval of 98% of the doctors and nurses in Northwest Ohio. But this woman would not back down. Women are always a problem, except for the one that I'm married to, of course. She basically shamed me into taking the chelation course. She pointed out that I had made a lot of money doing her 5 heart caths, that hadn't worked out well for her, and that basically I owed her, and she was right. So I took the course, learned about chelation, learned about oxidative stress, fatty acids, homocysteine, lipoprotein A. I learned a lot about integrative medicine, and I began to treat this patient with EDTA chelation therapy. Her angina and shortness of breath improved, and we kept her alive long enough for her to undergo successful cardiac transplantation. For me, this was the index case in the field of integrative cardiology, which I practice today and which I now teach to other doctors. I give a lot of presentations, and on our website are DVD presentations or links to audio-visual presentations on various aspects of integrative cardiology. In our first presentation, we're going to focus on phosphatidylcholine, PPC, and cardiovascular disease. We'll start with the historical development of PPC and cardiovascular disease, beginning with Dr. Jacobius Rinse. We'll talk about phospholipid and lipid nomenclature, the effect of PPC on lipid metabolism, the effect of PPC on vascular wall cholesterol metabolism, vascular rheology, platelet and red cell function, the use of PPC combined with EDTA in heavy metal detoxification, the effect of PPC on methyl cycle dynamics, and I'll present clinical studies and case reports. I will present the chemistry of PPC and how we can use PPC to correct the acquired abnormalities in our physiology that lead to cardiovascular disease and disease in general. Studies demonstrating benefit of PPC in disease states ranging from atherosclerosis to Crohn's disease to impaired memory will be presented. Much of this will be new to you. It is not critical that you commit to memory every detail of these presentations, but please follow along and gain an understanding of how PPC works. For if we understand how PPC works, then we can use this substance to obtain unique and quite favorable outcomes for our patients. That would be you, by the way. This gentleman obtained a unique outcome, pronounced coronary artery decalcification. Atherosclerotic plaque tends to calcify. The calcium score thus reflects plaque volume, which in turn reflects the long-term effect of the risk factors for atherosclerosis that you've borne over your lifetime. In allopathic drug-based cardiology, the goal is to delay progression of coronary calcification. The average rate of progression is 20% per year. Regression of calcification is not expected or even felt to be possible. This gentleman's baseline calcium score was nearly 1400. We would consider that to be heavy calcification. Now, atherosclerosis is not a diffuse disease, it's a focal asymmetric disease. And in this gentleman, calcification was greatest in his circumflex coronary artery, with lesser degrees of calcification and thus lesser degrees of atherosclerotic plaque in the left-hand ascending and right coronary artery. He was treated with 30 IV PPC treatments. As you will learn, PPC promotes egress of cholesterol from the vascular wall. In response to PPC treatment, cholesterol egressed from the vascular wall in this gentleman, and this correlated with marked decalcification. His total calcium score fell from nearly 1400 to 562, which I've never seen before. That's not supposed to happen. In the artery with the greatest volume of disease and the greatest baseline degree of calcification, there was the most pronounced decalcification. The right coronary artery was not severely diseased, not much happened. The left-hander ascending actually worsened a little. This is not unusual to see an asymmetric response. With any therapy, the artery that bears the greatest baseline disease is where we see the greatest benefit. Arteries that bear mild to moderate disease, we may see no change or slight worsening. But in any event, this degree of coronary artery decalcification is profound and reflects the power of PPC to have favorable effects on our arteries. So I hope this encourages you to listen to what I have to say, because we want these really positive and unique benefits to accrue to all of you. Our second discussion will cover the non-cardiovascular benefits of PPC and elaborate upon the physiologic benefits of this substance. As you will see, PPC provides powerful antioxidant and anti-inflammatory effects. PPC improves cell membrane function. PPC improves methyl cycle function. Any substance that provides antioxidant and anti-inflammatory effects, improves cell membrane function, and provides methyl cycle repair is going to protect our cells and our organs in any disease state. PPC provides benefit in reperfusion injury. PPC is of value in upper and lower GI tract inflammatory disease. PPC may have a benefit in neurologic health. Cardiomyopathy pertains to the use of PPC in liver disease, and this has geopolitical implications because, as Napoleon told us, an army travels on its liver, and you'll learn why the U.S. Army, in this regard, has a comparative advantage. PPC may reduce our risk for cancer. We'll talk about TMAO and at least theoretical downside of PPC supplementation. We'll talk about the anti-aging effects of PPC. I will summarize and I will provide references for part 1 and for part 2. Obviously, my passion is integrative cardiology, but I am board certified and university trained in internal medicine and invasive cardiology. Stated otherwise, I was taught, and over the first 10 years of my career, I practiced as I was taught, same as every other physician, that the proper focus of cardiology was on anatomy. There was a fixed blockage, a concretion, compromising the supply of oxygenated blood, rendering it insufficient to meet the needs of the exercising heart muscle. So my job was to do a coronary angiogram and determine the severity and extent of narrowings, and then make a recommendation as to how we could best resupply oxygenated blood with a revascularization procedure, balloon angioplasty, bypass surgery, later stent placement. If the pattern of blockages was not amenable to a resupply revascularization procedure, then we would use drugs to decrease heart rate, blood pressure, contractility, decrease demand of the heart for oxygen. Cardiology was all about supply and demand, fixed lesions. And of course, this is an appropriate approach to the patient in crisis. If you're having a heart attack, we need to do a heart cath and open up that 99% narrowing. But if we focus only on lesions and ignore the circulation, the abnormalities in your vascular biochemistry and cell biology that cause the plaque to develop in the first place, then you're going to be back with more trouble. And if we don't address the causes of cardiovascular disease, we will never be preventing this disease. Thus, our goal is to identify and help you resolve all the phenomenon that increase your risk of developing plaque deposition and experiencing adverse cardiovascular events. Phosphatidylcholine will lower your LDL cholesterol, but its key function is to deal with impaired HDL-mediated reverse cholesterol transport. Phosphatidylcholine will stimulate the removal of cholesterol from the vascular wall by optimizing HDL-mediated reverse cholesterol transport. Phosphatidylcholine will also lower oxidative and inflammatory stress, the key driving forces underlying cardiovascular disease and essentially all age-related diseases that we're dealing with. Atherosclerosis can be considered as a maladaptive response of the immune system to what it perceives as infection of the artery wall with oxidized cholesterol. We have a 3-part DVD presentation on this concept titled Immune Mechanisms of Atherosclerosis. Essentially, the natural predator of man is infection. Whether you believe in creation or Darwinian evolution, we've been evolving on this planet over the past 4 million years. We've become adept at recognizing infection and dealing with it. When primitive man was experiencing infection, he would experience oxidative stress. When we experience oxidative stress as a sign of infection, we will experience inflammatory stress. We will generate inflammatory cytokines. Now, when you're fighting an infection, you need to make white blood cells. Thus, you need to make cholesterol to make cell membranes for the white cells. You need sugar to fuel the white cells, so when you have an infection, cholesterol goes up, blood sugar goes up. You want to make inflammatory cytokines, bullets, to help the white cells kill the microbes. You want your immune system to be stimulated to go into battle to protect you from these marauding bacteria or viruses. The endothelium should activate and become porous because you want white cells to enter your tissues to kill the microbes. So oxidative inflammatory stress is appropriate when we're faced with a real infection. But modern man's not dying of infection, but modern man is experiencing oxidative stress due to maladaptive environmental cues, belly fat, a poor diet, sleep apnea, leaky gut, organic pollutants and toxins. We're experiencing oxidative stress. Mother Nature doesn't understand that the oxidative stress is coming from toxins and belly fat. She thinks we're involved with a chronic infection. So we have oxidative stress, inflammatory stress, hyperlipidemia, hyperglycemia, endothelial dysfunction, immune dysregulation, and this leads to cardiovascular disease. Now, hyperlipidemia is a result of oxidative inflammatory stress, is an age-related phenomenon that plagues most of us in the Western world. What is the fate of cholesterol that enters the vascular wall? Well, first of all, cholesterol, LDL cholesterol is food. Every cell in our body has an LDL receptor to recognize LDL cholesterol and incorporate it into the cell for proper use. Now, unbound free cholesterol that doesn't bind an LDL receptor can diffuse out. So high cholesterol itself is not going to cause cardiovascular disease. If it's not going to be bound to an LDL receptor, it's going to diffuse out in the circulation, unless it's trapped. Non-utilized cholesterol can be trapped. It will bind to proteoglycan, chondroitin sulfate within the artery wall, and it cannot diffuse out. There, it can become oxidized, it can crystallize, or it could esterify as atheroma. And we're going to be using phosphatidylcholine to remove cholesterol from atheroma. Now, so non-utilized and trapped cholesterol can be oxidized. When LDL is oxidized, it no longer looks like food. It no longer binds the LDL receptor. It is recognized by the scavenger or microbial recognition receptors of white cells. So when we have oxidized LDL in the vascular wall, we begin to mount an immune response against oxidized LDL, a response to chronic infection. it can crystallize within the artery wall. And we have little rocks, we have little stones in the artery wall. Or it can esterify as atheroma. Cholesterol that is unesterified can diffuse in and out of the vascular wall. But if it is esterified to a fatty acid, primarily oleic acid, then it gets stuck in the artery wall as atheroma. So let's talk a little bit about the mechanisms of atherosclerosis. Atherosclerosis begins when apolipoprotein B100 containing particles, LDL, LPA, and remnants, enter the artery wall, particularly if the lipids are in high concentration of small particle size. And again, this is not pathological. The LDL particles can bind the LDL receptor and be used as food. If not, they can diffuse out unless they are trapped. Phospholipase enzymes, which we'll talk about a little bit later, will alter the phospholipids on the LDL particle, causing it to clump together, and it gets stuck. It cannot diffuse out. It binds to proteoglycan, chondroitin sulfate within the vascular wall. It gets stuck. Then the LDL can be oxidized by free radicals generated by all of the cells within the artery wall. And when we have oxidized LDL, we begin to mount an immune response, and white cells are pulled in to deal with what Mother Nature perceives as an infection of the artery wall with oxidized lipids. Over the years, more LDL enters the artery wall, more white cells enter the artery wall, creating atheroma and this inflammatory response to perceived infection. Finally, we have the terminal event at a shoulder region of the plaque in an area that is characterized by intensive oxidative inflammatory stress, matrix and metalloproteinases released by macrophages in response to interferon gamma and other pro-inflammatory cytokines released by immune cells will degrade the fibrous cap, and this atheromatous gruel will flow out into the vascular lumen, causing a clot, and then we have a heart attack. Plaque destabilization or rupture, you can think of it as an out-of-control immune and oxidative frenzy within the vascular wall. So it's an oxidative and inflammatory bonfire. Atherosclerosis generates oxidative and inflammatory mediators. We need to neutralize those with antioxidant strategies. Otherwise, you're going to burn in an oxidative bonfire and have progressive atherosclerosis and suffer its consequences. Now, when the LDL is oxidized, it no longer binds the LDL receptor. It is recognized by a white cell as an infection, and then we will begin to generate white cells with receptors specific for oxidized LDL. They're going to rush into the artery wall and cause this chronic immune response. If you have a boil on your skin, that is an immune response to bacterial proteins that entered your body. If you have atherosclerosis, you have a boil in the artery wall teeming with white cells that are sensitized to oxidized LDL and other proteins in the artery wall. Now, another fate of cholesterol could be to crystallize. Now, consider gout. I think we're all familiar with gout. Crystals of uric acid will deposit in the joints. White cells will engulf these crystals, but because they're not microbes that can be digested, they're rocks. And this activates a sterile inflammatory pathway called NLR3, which mediates acute gout. Lots of sterile inflammation in the joint in response to these crystals of uric acid. The same thing happens to coronary arteries. Crystalline cholesterol within the artery wall will be engulfed by white cells. They can't break it down. We activate the NLRP3 pathway, and we have an inflammatory response. Unstable angina, heart attack, often involves this sterile inflammatory response to crystalline cholesterol in the artery wall. And of course, we can deal with this with colchicine, and we have a 90-minute presentation on how we can attenuate atherosclerosis and its consequences with colchicine. So cholesterol particles that are trapped within the artery wall and subsequently oxidized will stimulate a maladaptive response of the acquired immune system. Trapped cholesterol particles that crystallize will stimulate a maladaptive response to the innate immune system. Free cholesterol can also be esterified with oleic acid to form cholesterol oleate, which makes up atheroma. We're going to be using polyenylphosphatidylcholine, that is phosphatidylcholine enriched in unsaturated fatty acids, primarily linoleic acid, to block cholesterol esterification within the artery wall, to promote cholesterol oleate deesterification, and then reesterification of the free cholesterol to linoleic acid within the HDL particle to stimulate reverse cholesterol transport. We're going to be using 1,2-dilinolenophosphatidyl-choline to block cholesterol deposition within the artery wall as atheroma and to promote removal of this trapped cholesterol from the artery wall, thus reversing atherosclerosis. Phosphatidylcholine consists of a 3-carbon glycerol backbone to which is attached 2 fatty acids. If the fatty acids are linoleic acid, that will create 1,2-dilinolenophosphatidyl-choline, which is the most powerful phosphatidylcholine with respect to blocking cholesterol oleate formation and promoting reverse cholesterol transport. The material that we use, lipostabile and essential phosphol plaque X, is 80% 1,2-dilinolenophosphatidyl-choline. That's phosphatidylcholine with linoleic acid in the 2nd and 3rd carbon positions. This is a Stewart model of 1,2-dilinolenophosphatidyl-choline. This is the phosphatidyl-choline head group. These are the 2 linoleic acid side chains. You'll notice they have a bend in their structure that's characteristic of an unsaturated fatty acid. The term polyenylphosphatidylcholine strictly refers to phosphatidylcholine with 2 unsaturated fatty acids in the 2nd and 3rd carbon positions. The material that we use clinically contains 80% linoleic acid. So we refer to this material as polyenylphosphatidylcholine, PPC. In Europe, it's sometimes referred to as essential phospholipid, or EPL. Let's talk a little bit about lipid nomenclature. This is a saturated fatty acid. All the carbons are saturated with hydrogen. There's a methyl end and a carboxyl acid group. This is a saturated fatty acid. An unsaturated fatty acid has 1 or more double bonds. This introduces a bend into the fatty acid. A triglyceride, like phosphatidylcholine, has a 3-carbon backbone, but all 3 carbon positions are bound by fatty acids. The characteristics of a triglyceride will relate to the fatty acids with which it is composed. A phospholipid has the 3-carbon backbone. It has 2 fatty acid side chains and then a phosphorylated head group. Steroids like vitamin D, cholesterol, testosterone are ring structures of carbon. Phospholipid versus triglyceride structure. A triglyceride has the 3-carbon backbone to which is bound 3 fatty acids. A phospholipid has the 3-carbon backbone with 2 fatty acids. The 3rd carbon position is bound to phosphate and another molecule here. It's a choline molecule, thus this is phosphatidylcholine. Phosphatidylcholine molecules are considered to be bipolar in their chemical characteristic. The phosphatidylcholine head group is water soluble. It is hydrophilic. It can interact with an aqueous or water environment. The 2 fatty acids are lipophilic. They will not interact with water. They will interact with other fatty materials. Our cells are surrounded by a skin, a lipid bimembrane. Interacting with the aqueous environment outside of the cell, a watery environment, we have the polar, hydrophilic, water-loving phosphatidylcholine head groups. Interacting with the aqueous environment, the water within the cell, we have the same hydrophilic phosphatidylcholine head groups. The core of the cell membrane will be the fat-soluble fatty acids of the phospholipid. So within our cell membrane and the functional centers within our cells, the organelles, all have a skin of a phospholipid bilayer. Embedded within the cell membrane are channels and pumps and enzymes. Most of our biology is carried out on the cell membrane or the membranes of the intracellular organelles. When we are young, the cell membrane is flush with phosphatidylcholine composed of unsaturated fatty acids. There's lesser amounts of saturated fatty acids, there's less cholesterol. As we age, the phospholipids drop out. We have more saturated fatty acids, more cholesterol. The cell membrane is no longer fluid and elastic and functional. It's stiff. The enzymes don't work. This is part of aging. If we treat you, however, with unsaturated phosphatidylcholine, we can restore our more youthful characteristics to your cell membranes and the membranes that surround all the functional centers of your cells, the nucleus, the mitochondria, etc. Triglycerides are degraded by enzymes known as lipases. ACEs refers to an enzyme that breaks something down. So we have the triglyceride, the 3-carbon glycerol backbone to which is attached 3 fatty acids. A lipase will split off one of the fatty acids to create a diglyceride and a free fatty acid. The next step will be to break off another fatty acid to generate a monoglyceride and another free fatty acid. Phospholipids are degraded by enzymes termed phospholipases. Phospholipase A1 snips off the fatty acid attached to the first carbon of a phospholipid. Phospholipid A2 snips off the fatty acid attached to the second carbon. C and D snip away before and after the attachment of the phosphorus group to the third carbon atom of a phospholipid. You're hearing a lot about phospholipase A2 as a marker of atherosclerotic risk. Phospholipase A2 is stimulated within the vascular wall by oxidative and inflammatory stress. Phospholipase A2 will create a lysophosphatidylcholine, which, if found in the artery wall, is a sign of inflammation, and it will also release a free fatty acid. And if we're following a poor diet and that we're taking in a lot of the pro-inflammatory omega-6 arachidonic acid, thus phospholipase A2 will release an inflammatory fatty acid mediator and lysophosphatidylcholine, which within the artery wall stimulates an inflammatory response. When we see lysophosphatidylcholine in the artery wall, that's a sign that something's not right. Inflammation is present. The endothelial cells that line our arteries activate, and they begin to pull in white cells to investigate what the body thinks is an incipient infection. While oxidative inflammatory stress will upregulate the expression of phospholipase A2 in the artery wall, our material, PPC, polyenylphosphatidylcholine, will downregulate phospholipase A2 within the artery wall, blunting the release of potentially pro-inflammatory omega-6 fatty acids and the generation of lysophosphatidylcholine. Let's talk about fats. Fat should compose 10 to 20% of our energy intake. Fat is fattening. Fat provides 9 calories per gram. Protein and carbohydrate provide 4 calories per gram. Fat is composed of carbon, hydrogen, and oxygen. Fat exists in our food supply and in our bodies as triglyceride. Whether a fat is good or bad relates to whether the fatty acids with which it's composed are good or bad. We can characterize fatty acids in terms of are they saturated versus unsaturated, cis versus trans, essential or unessential. Saturated fatty acids. Within a saturated fatty acid, all the carbons are bound to 2 hydrogens. The carbons are saturated with hydrogen. The hydrogen atoms tend to repel one another, but as we have equal and opposite forces on either side of the carbon, we create a linear structure. So saturated fatty acids are linear, they stack together well. Think of a box of pencils. You can shake it, but the pencils aren't going to move around much. We get saturated fatty acids from animal meat and dairy sources. They tend to be solid at room temperature, like animal fat and butter. They tend to raise cholesterol and triglycerides. They tend to cause obesity and heart disease. Saturated fats have no unique nutritional value. We can exist without saturated fats. The only value that saturated fats provide to us is as a source of energy. We want to minimize our saturated fatty acid intake, so don't eat this stuff. Conversely, unsaturated fatty acids contain 1 or more carbon-to-carbon double bonds. Oleic acid is a monounsaturated fatty acid. There's a void here without hydrogen, so these hydrogens will repel one another and the molecule will have a bend. Gamma-linolenic acid is a polyunsaturated fatty acid with several carbon-to-carbon double bonds, so this molecule will contain multiple bends. They're not saturated with hydrogen, one or more carbon-to-carbon double bonds. They tend to be liquids at room temperature. Consider a box of paper clips. You can shake them, but they won't fit together tightly, therefore they will be mobile. If you take the paper clip out and you bend it, and then you put it back in the box and you shake it, they'll move all over the place. So if our cell membranes contain unsaturated fatty acids, the cell membrane will be fluid and elastic and functional. Conversely, if the cell membrane contains only saturated fatty acids, it'll be rigid and stiff. Unsaturated fatty acids are liquid at room temperature, such as olive oil. We obtain them from vegetable sources. Monounsaturates have an antioxidant effect. Extra virgin olive oil contains monounsaturated fatty acid that provides an antioxidant effect. Unsaturated fatty acids tend to lower cholesterol, triglycerides, and help prevent obesity and heart disease. They're desirable. So again, saturated versus unsaturated. In a saturated fatty acid, all the carbons are saturated with hydrogen. These are linear structures. They will be solid at room temperature. We can call these hard fats, such as butter. Within an unsaturated fatty acid, there's one or more carbon-to-carbon double bonds. The fatty acids don't fit together well. They tend to be liquid at room temperature. They have nutritional value. The saturated fatty acids, their use to us is only as a source of fuel. Cis versus trans. In nature, essential fatty acids exist in the cis configuration with the bend characteristic of an unsaturated fatty acid. Trans fats are man-made fats. As a general rule, whenever mankind alters our food supply, no good will follow. And trans fats have no nutritional value, and they actually act as metabolic poisons. Trans fats were invented by the vegetable oil industry to help them make money. They wanted to market liquid vegetable oil as an alternative to solid butter. But you don't want to pour corn oil on your toast. You want to spread a solid substance. You want to spread butter. So what they tried to do was convert liquid, healthful, unsaturated vegetable oil into a solid, non-healthful saturated fatty acid. So they would take the oil and put it in big vats and heat it and apply pressure, and in the presence of a catalyst such as aluminum, they would bubble in hydrogen gas to convert the unsaturated fatty acid into a saturated fatty acid that would look and act and taste like butter. The problem is the chemical reaction did not go to completion, and some of the molecules contained hydrogens on opposite sides, and this is called a trans configuration. Now, the trans fat will be linear. It will act like a saturated fat. It tastes pretty good, and this is what margarine is. Partially hydrogenated vegetable oils. They take vegetable oil, bubble in hydrogen gas. They create some saturated fats, but they also generate these trans fats. Now, they're linear, but there's a slight distortion in the configuration of the molecule. The problem here is that enzymes that will convert healthful unsaturated fatty acids into anti-inflammatory mediators, or to utilize them within the cell membrane, will be poisoned by the trans fat. The trans fat acts like a key that's not quite right for the lock. You can't open up the door, but then you can't get the key out. So trans fats will poison our enzymes. So you can take in a lot of healthful unsaturated fatty acids, but if you're also taking in trans fats, those unsaturated fatty acids will not be of value to you. We all made fun of Mayor Bloomberg when he banned trans fats in New York City, but Mayor Bloomberg had it right. Trans fats are metabolic poisons. We must avoid the intake of trans fats. Essential fatty acids. In contrast to saturated fatty acids, which the human body can generate and which we utilize only as a source of fuel, the human body cannot generate essential fatty acids. We must obtain essential fatty acids from diet. Saturated fatty acids are a fuel, while essential fatty acids participate in structure and function. Unsaturated fatty acids are the raw materials from which we generate prostaglandins. Prostaglandins can be used to mount an inflammatory response when an inflammatory response is appropriate. Let's say we have a legitimate infection, we need to mount an inflammatory response. We will utilize pro-inflammatory prostaglandins derived from essential fatty acids. However, outside of the context of infection, we want our physiology to assume an anti-inflammatory posture. Thus, we wish to generate anti-inflammatory prostaglandins. Prostaglandins are intracellular secondary messengers mediating multiple physiologic processes, including fever, pain, and inflammation, or resolution of fever, resolution of pain, resolution of inflammation. Brown fat metabolism to burn excessive calories to maintain trimness, blood platelet adhesiveness, and vascular tone. We need a balanced intake of essential fatty acids to provide balanced prostaglandin formation. The problem is the American diet is deficient in essential fatty acids. The American diet is rich in essential fatty acid blockers like trans fats. Thus, Americans have an unhealthful prostaglandin mix. Thus, we in the West assume a pro-inflammatory posture. We can nutritionally bypass this problem with essential fatty acids, the omega-3, EPA and DHA, and the favorable omega-6 GLA, and by avoiding trans fats. We have a DVD that discusses essential fatty acids, which I will refer you to. We should be taking in 20% of our calories as fat. That was the situation in 1800. But over the past 200 years, we've been increasing the percentage of our calories that are derived from fat. That is not helpful. To make matters worse, the quality of the fat that we're taking in is also changing. We're taking in more saturated fats. We invented trans fats, which are metabolic poisons. We're taking in less healthful unsaturated fatty acid, and more of it is omega-6, which tends to be pro-inflammatory, less omega-3, which is anti-inflammatory. We have an unhealthful mix of prostaglandins because we have an unhealthful mix of fatty acids in our diet, not enough omega-3, too much saturated, too much trans, an increased ratio of omega-6 to omega-3. We are out of balance. We need to rectify this situation by increasing intake of omega-3 fatty acids such as flax oil and fish oil. We can take in healthful cis fatty acids from vegetable oil sources. We wish to take in proper vitamins and minerals to convert the raw materials into the favorable prostaglandins of the 1 and 3 series, which are anti-inflammatory, vasodilatory. They blunt platelet adhesiveness. We want to cut back on arachidonic acid intake. We get that from red meat and dairy. This is an omega-6 unsaturated fatty acid that will be metabolized into prostaglandins of the 2 series and leukotrienes of the 2 series, which promote pain, inflammation, blood platelet adhesiveness. So we want to modify our diet, enrich ourselves with healthful cis unsaturated fatty acids, cut back on arachidonic acid, make sure we have the proper biochemical milieu to convert the raw materials into the finished products, so we have appropriate vitamins and minerals, so we can restore our prostaglandin balance back into a pro-inflammatory posture. You now have an understanding of essential fatty acid metabolism, and I think that you understand that cis unsaturated fatty acids obtained from vegetable sources are favorable. In fact, they're necessary for proper cell membrane function and for proper prostaglandin formation and utilization. You wish to minimize saturated fatty intake, which is useful only for fuel, and you wish to avoid, like the plague, trans fats, which are metabolic poisons. Now I'd like to talk about cholesterol esterification and deesterification, which pertains to the use of PPC in the prevention and treatment of coronary artery disease. Oleic acid itself is not a bad guy. It is a cis unsaturated fatty acid. However, enzymes that are upregulated in the presence of systemic inflammation, oxidative stress, a high saturated fat diet will esterify free cholesterol with oleic acid, forming cholesterol oleate, a cholesterol ester. Free cholesterol can diffuse in and out of the artery wall, but when it is esterified with oleic acid, it is stuck, it is immobile, and it will accumulate within the artery wall as atheroma, which participates in the formation of atherosclerotic plaque. The gruel within a plaque is a pool of cholesterol oleate. PPC, which we're going to use clinically, will blunt cholesterol esterification within the artery wall with oleic acid. It will stimulate the enzymes that will break this bond and de-esterify cholesterol oleate to generate free cholesterol, which is then re-esterified with linoleic acid to form cholesterol linolenate, which is then loaded up in the HDL to be taken out of the artery wall. PPC will promote reverse cholesterol transport. This is an animal model where the animals are fed an atherogenic diet. I think it was like 20% beef tallow. And this will stimulate systemic inflammation, oxidative stress, and the incorporation of oleic acid into cholesterol ester. If the animals are fed the atherogenic diet and they receive PPC, you can see that the PPC is blocking the incorporation of oleic acid into cholesterol ester. It will block the formation of atherosclerotic plaque. The material that we're using, PPC, often referred to in the European literature as essential phospholipid and marketed as a pharmaceutical under the trade names Lipostabile or N-Essential, and available generically in the United States as Phoscol or Plaquex, is phosphatidylcholine enriched with linoleic acid, is predominantly 1,2-dilinolenyl phosphatidylcholine. The raw material utilized to generate PPC is soybean, sunflower, or safflower phosphatidylcholine, which is enriched in unsaturated fatty acids. They distill this material, they heat it, and different fractions will vaporize at different temperatures. They capture the fraction enriched in linoleic acid. The PPC that we use, 81% of the fatty acids attached to the second carbon position are linolenate, 52% at the first carbon position. So the PPC that we use, 2/3 of the fatty acids are linoleic acid. The phosphatidylcholine story began when I was in junior high, when Jacobius Rinse, a Canadian oil chemist, began to experience chest tightness while he was hiking the hills outside of Toronto. Rinse sought consult with the leading cardiologists in Ontario, and these physicians advised Rinse to stop exercising and to cut back on the cholesterol content of his diet because, as everyone knew, hardening of the arteries, atherosclerosis, was an adverse interaction between too much exercise and dietary cholesterol. Well, Dr. Rinse listened to the advice of his cardiologist, but he wasn't sure that this advice was optimal because Rinse had observed that people who exercise enjoy relative freedom from cardiovascular disease. Rinse was also concerned regarding the admonition that he eliminate cholesterol from his diet because Rinse knew that cholesterol was a normal component of the human diet. Thus, Rinse went to the literature to learn all he could about cholesterol metabolism. Rinse learned that cholesterol was a key raw material. Every cell of the body bears an LDL cholesterol receptor. To allow every cell to bring LDL cholesterol into the cell, because our body is going to utilize 800 milligrams a day of cholesterol for proper function. If we don't obtain adequate cholesterol from the diet, the liver will generate it. We need cholesterol to make vitamin D, to make bile acids to help us absorb fat-soluble vitamins and nutrients, to make steroid hormones, to make cell membranes, such as if we are going to mount an appropriate response to infection, we're going to make more white cells, so we need cholesterol to make cell membranes for the white cells. Indeed, cholesterol is a key raw material. So if cholesterol is a key raw material, why were Rinse's cardiologists advising him to limit dietary cholesterol intake? Rinse learned that cholesterol obtained from the diet or cholesterol generated in the liver, was a waxy, blood-insoluble material. So the body will generate a protein called an apolipoprotein, bind it to cholesterol to make a blood-soluble LDL particle. It is the job of the LDL to ferry cholesterol from the liver to meet the needs of our cells to fulfill their cholesterol requirement. Rinse also learned that there's a reverse pathway through which used or excessive cholesterol can be removed from the body cells or from the cells of the artery wall and taken back to the liver, and that was the HDL reverse cholesterol transport pathway. Now, Rinse was an oil chemist. He made his living setting up and running chemical factories. Rinse never had a problem with too much raw material, but his chemical factories would not function properly if he lacked the proper catalyst to help convert the raw material to the finished product, or if he was running the chemical reactions at an improper temperature or with an improper pH. So Rinse hypothesized that the problem with his chemical factory, his physiology, was that he lacked the proper enzymes, that would be the biological equivalent of a catalyst in a chemical factory, to help him process cholesterol properly. Rinse hypothesized that his reverse cholesterol transport pathway was not functioning properly because he lacked the proper enzymes and the proper raw materials to promote HDL-mediated reverse cholesterol transport. And he came up with a corrective action called the Rinse formula. The utility of the Rinse formula and its modern-day expression, PPC, is not to lower serum cholesterol. PPC will lower serum cholesterol, but its primary use is to promote reverse cholesterol transport, to remove cholesterol oleate from the artery wall. Before we talk about the use of PPC to carry out reverse cholesterol transport, improve coronary blood flow, and lower plaque volume, let's talk a little bit about how the body manages serum cholesterol. Your serum cholesterol is governed primarily by the level of expression of the LDL cholesterol receptor in the liver. That is the expression of the hepatic LDL receptor. The liver will generate and express LDL receptors in relation to its perceived need for cholesterol in the liver. So your serum cholesterol level relates to the level of expression of the hepatic LDL receptor, which in turn relates to the liver's perceived need for cholesterol. This is not your doctor's opinion as to what your serum cholesterol should be. It relates instead to what the liver perceives as its need for cholesterol. How does this all work? This diagram is relatively tedious, but please follow along with me, because if we understand how the liver decides whether to express or not to express the LDL receptor, we're going to understand how diet and drug therapy influences cholesterol. You're going to understand how statins work, and you'll also understand the downsides of statin therapy, downsides that we can understand and mitigate. The liver has a free cholesterol sensor called INSIG. When INSIG thinks that there's enough cholesterol to meet the needs of the liver cell, it will sequester SREBP. That is sterile regulatory element binding protein to a chaperone called SCAMP. Thus, the sterile regulatory element binding protein cannot translocate into the nucleus and generate new LDL receptors. There's plenty of cholesterol. Why would you need to make more LDL receptors? Conversely, if the level of free cholesterol in the liver cell is poor, perhaps because you're on a low cholesterol diet, or perhaps because you're taking a statin drug to block the generation of cholesterol, or perhaps because you're starving, we need to remember that this was all set up by Mother Nature to help mankind maintain a normal serum cholesterol during times of starvation. If there's not enough cholesterol in the cell, INSIG senses that and activates SCAP, which is sterile regulatory element binding protein, cleavage activating protein. What SCAP will do will snip some amino acids off SREBP, freeing it from sequestration and allowing it to translocate into the nucleus, where it will begin to generate LDL receptors. So if we don't have enough cholesterol in the cell, we're going to make LDL receptors to help the liver pull serum cholesterol out of the serum into the liver cells to meet the needs of the liver. That makes a lot of sense. So if the level of free cholesterol within the cells of your liver is low, because you're on a low cholesterol diet, or you're taking a statin drug that blocks the generation of cholesterol, or if you're starving, the sterile regulatory element binding protein will translocate to the nucleus. You'll make more LDL receptors. The liver will then pull LDL cholesterol out of the circulation to meet its needs. And this is how statin drugs in a low cholesterol diet work. But we have to remember that this physiology was set up not to make us good statin takers, but to help mankind thrive in situations where dietary cholesterol may be suboptimal. So if we are starving, cholesterol in the liver will be low, so you're going to make more LDL receptors to pull cholesterol out of the circulation to meet the liver's needs, but you're also going to increase expression of HMG-CoA reductase. That is the rate-limiting enzyme with respect to cholesterol generation. HMG-CoA reductase is the rate-limiting step in the generation of cholesterol and downstream oxidative and inflammatory mediators. When primitive man experienced a real infection, primitive man would experience oxidative and inflammatory stress. That leads to appropriate upregulation in the activity of HMG-CoA reductase to make cholesterol, to generate cell membranes for the white cells that you would need to fight infection, and downstream bullets, oxidative and inflammatory mediators. When we were in our 20s, we were not experiencing oxidative and inflammatory stress. HMG-CoA reductase was not upregulated. We all had a normal cholesterol. As we age, we accumulate phenomenon that stimulate oxidative stress and inflammation. We put on belly fat. We develop gingivitis. We develop sleep apnea. We accumulate heavy metals and organic pollutants. So we're generating oxidative inflammatory mediators, not in relation to legitimate infection, but these oxidative inflammatory mediators upregulate expression of HMG-CoA reductase, and we're suffering from hyperlipidemia and downstream overexpression of oxidative and inflammatory mediators. Now, within the framework of integrative medicine, we seek to remove from your physiology these pro-inflammatory, pro-oxidant cues. So we would recommend changing your diet, losing weight, dealing with leaky gut, dealing with sleep apnea, remove the organic pollutants and remove the heavy metals. Return your physiology to the pristine state that it enjoyed when you were younger. In allopathic drug-only cardiology, we don't spend a lot of time dealing with the causes of oxidative inflammatory stress. We just give you statins, because if we give you a statin, we will, in a sense, attenuate some of the negative effects of chronic oxidative inflammatory stress, and that is how statins are utilized. Now, I'm a cardiologist, and I'm expected to put everyone on statins. American watch TV ads that talk about the virtue of taking a statin, and I'm expected to put you on statins. When I give a presentation at an integrative medicine meeting, if the attendees don't know me and don't know what I'm all about, they just assume that I'm going to be a statin pusher, and they'll ask me questions about statins and question the utilization of statins. Conversely, in my own community, I'm considered anti-statin. I'm considered anti-statin because I don't put everybody I see on high doses of statins. Now, in truth, I am not anti-statin. I am not pro-statin, nor was I for statins before I was against statins. I will use statins when statin therapy is appropriate. If you are at risk of experiencing an adverse cardiovascular event in the next 1 to 2 years, and you have inflammation, you have oxidative stress, you have a high cholesterol, it makes sense to put out the fire with a statin that will buy us time to do the more important work to remove the oxidative and inflammatory cues that are causing your body to inappropriately upregulate expression of HMG-CoA reductase. Now, we can also intervene nutraceutically, and we can do that because I've spent a lot of time understanding how statins work. Now, we can inactivate HMG-CoA reductase and mark it for degradation if we phosphorylate it. There's an enzyme called AMP-sensitive protein kinase that will phosphorylate, thus downregulating HMG-CoA reductase and marking it for degradation. We can upregulate AMP-sensitive protein kinase with exercise, weight loss, nutraceutical interventions such as berberine or acetic acid from vinegar. Then we will downregulate the expression of HMG-CoA reductase, will block generation of cholesterol, and will block the generation of downstream oxidative inflammatory mediators. We have nutraceutical statins. I call these green statins. Red yeast rice extract, amla, and bergamot will downregulate H-chemical reductase, but because these are plant-based substances, the liver breaks them down readily, and we are far less likely to experience side effects with these green statins than we are with the pharmaceutical statins. Delta tocotrienol will ubiquinate this enzyme, and that marks it for degradation. So we have a number of means of nutraceutically blunting H-chemical reductase. So I may use a pharmaceutical statin or I may use a nutraceutical statin. I will accomplish the same goal, and this will sort of put out the fire and buy us time to permanently remove from your physiology the causes of inappropriate oxidative inflammatory stress that cause you to increase expression of this enzyme, generating excessive cholesterol and downstream oxidative inflammatory mediators. So you take a statin, a pharmaceutical statin or a green statin, and blunt the generation of cholesterol within these cells of the liver. The liver cells will thus make LDL receptors to pull cholesterol out of the serum to meet needs of the liver. That's how we will use these agents to lower your serum cholesterol. Again, this system was not generated to make us good statin takers. It was designed to promote proper cholesterol levels in the liver, in the circulation, and within all the cells of the body. When Mother Nature takes a step in one direction, she typically takes an equal and opposite step in the other generation. So when we lower the cholesterol content of the liver cells, we're going to make more LDL receptors. We're also going to make more H-chemical reductase. So you take a statin to block the activity of H-chemical reductase. Mother Nature responds by making more H-chemical reductase. So I put you on a statin, your cholesterol drops, you come back a year later, it's back up. It's not as high as it was pre-statin, but it rose. Now, I used to attribute this to complacency. So we lower your cholesterol with the drug, and then you loosen up on your diet, and sometimes we do that. But the real reason that your cholesterol is rising following statin therapy is your body, in response to statin therapy, is making more H-chemical reductase. And to make matters worse, when you take a statin and lower cholesterol within the liver cells, you'll also increase expression of a molecule called PCSK9, which stands for proprotein convertase subtilisin Kexin 9. PCSK9 degrades the LDL receptor. PCSK9 inhibits the ability of the liver to pull LDL cholesterol out of the circulation and into the liver cells to meet the needs of the liver. Well, why do we make PCSK9? PCSK9's role in terms of evolution, I believe, is to prevent the liver from hogging all the cholesterol during starvation. So let's say you're starving, there's not enough cholesterol in the liver is going to make LDL receptors to pull LDL from the circulation to meet needs of the liver. You're going to make more H-chemical reductase so the liver can generate more of its own cholesterol. But what about the rest of the body? If the liver is going to hoard all the cholesterol during starvation, the rest of the body will suffer from cholesterol insufficiency. Thus, we have PCSK9. PCSK9 will be generated along with LDL receptors, along with H-chemical reductase, when there's inadequate cholesterol in the liver. The PCSK9 will blunt the expression of the LDL receptor, and this will provide a balancing act so the liver can generate the cholesterol it needs without starving the rest of the body. From a point of view of pathophysiology and patient care, when you take a statin to generate more LDL receptors, you're going to generate more H-chemical reductase, and you're going to generate more PCSK9. So statin therapy sows the seeds of its failure. If we are inflamed, if we have an infection, we will be experiencing lipopolysaccharide in our circulation. That is the material that makes up the cell membrane of gram-negative bacteria. So when we have inflammation, we have infection, we make more PCSK9. Why? Because the cells of the body will need more cholesterol. We need cholesterol to make the cell membranes of white cells to fight the infection. So in response to chronic inflammation, which most of us are experiencing, we're making excessive PCSK9, and that's preventing us from lowering our serum LDL cholesterol. Statin drugs increase the generation of H-chemical reductase and PCSK9, sowing the seeds for their dysfunction. So Big Pharma has come out with PCSK9 inhibitors. These are monoclonal antibodies that inhibit PCSK9. And if you are on a statin and we can't get your cholesterol to the desired level, one of the reasons is because you're making PCSK9. Many people just can't tolerate statins and you're left with hyperlipidemia. So we treat you with these PCSK9 inhibitors. It is a subcutaneous injection you do at home every 2 weeks, and it will dramatically lower your cholesterol. And this is a breakthrough that is quite helpful when I really need to lower your cholesterol and I cannot lower your cholesterol via diet, exercise, statins, or nutraceutical means. Now, PCSK9 doesn't really appear to be necessary for modern man. It was important to protect modern man from extra hepatic cholesterol deficiency during starvation, but modern man is not dying of starvation. PCSK9 no longer appears to be necessary. If we inhibit it, we can do so without ill effects. There are individuals who on a genetic basis don't make PCSK9. They live long and healthy lives with an LDL between 40 and 50. So PCSK9 direct inhibition is a new tool to help us lower serum cholesterol. Before we leave this section, which focuses on LDL receptor dynamics, I'd like to point out that berberine, the nutraceutical agent that I recommend to nearly all my patients with coronary disease or hyperlipidemia, will selectively block PCSK9 transcription. So if you're taking a statin or you're on a low cholesterol diet or you're taking a drug that blocks cholesterol absorption from the diet, intracellular cholesterol will be low, the liver will make more LDL receptors, that's desirable, it'll pull cholesterol out of the circulation. It will also make more HMG reductase, the enzyme that generates cholesterol, that's undesirable. And of course, what's really undesirable is that the liver will make more PCSK9, which will block the LDL receptor and raise your cholesterol. So we can treat you with the prescription agents that bind up and neutralize PCSK9, and they provide a powerful lipid-lowering effect. Or we could co-treat you with berberine. Berberine will block the transcription of PCSK9. So if we're blocking the generation of PCSK9 with berberine, we would expect a synergy between berberine and any other methodology that we might use to lower your cholesterol, be it drug or diet. So let's see what happens if we co-treat patients with statins and berberine. In this study, they looked at patients on maximally tolerated statin or statin plus ezetimibe. Ezetimibe blocks cholesterol uptake from the GI tract. And they added just 500 milligrams of berberine, a really low dose, and they saw a synergy. Maximal reduction in cholesterol and LDL was improved when you co-treat patients with berberine and maximally tolerated doses of statins. They also noted that the greater the degree of reduction in LDL with statin, the less was the kick with just 500 milligrams of berberine. And that's because the greater the statin dose, the greater will be the generation of PCSK9, the greater will be your relative need for berberine. So statins will increase PCSK9. The greater the statin dose, the greater will be the rise in PCSK9, the greater is your relative need for berberine. So I typically start my patients on 500 milligrams of berberine twice a day, but if you're on a high statin dose, I know that you may need more berberine, and I will make adjustments in your berberine to obtain the maximal synergy with your statin drug or any other methodology. Berberine is my favorite nutraceutical. It will lower cholesterol, it will lower blood sugar, it will lower generation of inflammatory and oxidative mediators. Berberine is of great value in the prevention and treatment of cardiovascular disease. And as Mr. Timnis tells Lucy in the Chronicles of Berberine, it's all about PCSK9. I'm going to refer you to the Chronicles of Berberine presentation. So we've talked about LDL receptor dynamics and how the liver is making decisions as to how it should be governing serum cholesterol. And let's now leave this section on LDL receptor dynamics and return to the wisdom of Jacobius Rinse and focus more on stimulating reverse cholesterol transport, pulling cholesterol out of the artery wall by stimulating less than cholesterol acetyltransferase with unsaturated phosphatidylcholine. To review, cholesterol obtained in the diet or cholesterol generated in the liver is bound to a protein to form the blood-soluble LDL particle. It's the job of the LDL to ferry cholesterol from the liver to meet the needs of the cells of the body. If you have atherosclerosis, as a general rule, the lower the LDL, the better. The lower the serum LDL, the less impetus will there be for LDL to be incorporated into vascular plaque. And thus, we've discussed strategies to lower your serum LDL, primarily by lowering the content of LDL in the liver. So the liver responds by making more LDL receptors to pull it out of the circulation. Now we're going to return to our main topic, the use of unsaturated phosphatidylcholine to promote reverse cholesterol transport. Unsaturated phosphatidylcholine will stimulate less than cholesterol transferase associated with HDL to esterify cholesterol with linoleic acid and pull it out of the artery wall. And this is how Jacobius Rinse treated himself. So the HDL particles are generated by the liver, and when they leave the liver, they're not enriched in cholesterol. They're a disc. And then in response to cholesterol esterification with linoleic acid via LCAT, the HDL becomes spherical, and it's then loaded up with cholesterol, taken from the artery wall, you take it out to the liver. So LCAT, less than the cholesterol transferase, will take a fatty acid from the second carbon position of phosphatidylcholine to make a cholesterol ester, cholesterol linolenate. And then the cholesterol ester is taken up by the HDL, cleared to the liver. PPC will promote deesterification of cholesterol oleate within the vascular wall. Thus, that free cholesterol will be reacylated by LCAT to cholesterol linolenate, taken up by the HDL, taken out through the liver. The fate of vascular wall cholesterol, again, it can be oxidized, and then it'll be mistaken by the immune system as a microbial invader. So how are we going to deal with this? We're going to deal with oxidative stress. Everything we can do to balance free radical generation with antioxidant neutralization, and then immune modulation. I will use agents that quiet down the immune system when it's overzealously active within the artery wall, creating inflammatory cytokines and free radicals. If it's crystallized, it can be mistaken by the immune system as an undesirable particulate, and we can block that with colchicine. We have a 90-minute presentation on colchicine. If you have coronary disease and you're on all the drugs, and I add in colchicine, we will dramatically decrease your risk of unstable angina, stroke, etc., because we're blocking this, what I will call gouty arteritis, when the immune system engulfs these crystals of cholesterol and mounts an inflammatory response. Or the focus of our presentation right now, it can be esterified. Cholesterol will be bound to oleic acid to form cholesterol ester, and the atheroma, the gruel in the artery wall, is cholesterol ester. And we're going to use PPC to promote deesterification, followed by reverse cholesterol transport to pull cholesterol out of the atheroma into the HDL, back to the liver, and out of the body. So Rinse had this all figured out. He didn't have too much cholesterol, but his chemical factory was deficient in phosphatidylcholine, so his HDL was not working properly. So by taking phosphatidylcholine, he promotes deesterification of the cholesterol esters. Phosphatidylcholine also blocks esterification of cholesterol within the artery wall, and it stimulates reverse cholesterol transport. So you're deesterifying cholesterol oleate, you have free cholesterol, you're stimulating LCAT associated with HDL, so you form cholesterol linolenate that's taken up by the HDL, taken out of the artery wall. So Rinse figured this out when I was in junior high and fixed his biochemical pathway to begin to pull cholesterol out of the artery wall. Now, so Rinse came up with the Rinse formula, sometimes called the Rinse morning feed. And the basics were soybean lecithin. Now, soybean lecithin, which is the raw material from which we make PPC in Europe as N-essential or as lipostabile, is enriched with linoleic acid. It's not 100% linoleic acid, but it's predominantly linoleic acid. So he would take that orally along with safflower oil. Why would he do that? Well, we take in lecithin, phosphatidylcholine, with the two fatty acids. Before it gets absorbed into the small intestine, phospholipases will degrade one of the fatty acids. So what we actually absorb is a lysolecithin, a lecithin, a phosphatidylcholine with one as opposed to two fatty acids. As soon as it enters the bowel wall, it will be reacylated with whatever fatty acid is present back in a phosphatidylcholine. So safflower oil or sunflower oil is rich in linoleic acid. So you take them together, so when the lysolecithin is going to be reacylated, if there's a lot of linoleic acid there, you're more likely to the final product of absorption will be a phosphatidylcholine rich in linoleic acid. That was the basis of the Rinse formula. Now, Rinse was a well-regarded chemist, and he hung around with a lot of smart people, and he learned from the Shute brothers that vitamin E was a good idea, so we added that in. Dr. Patterson had shown that vitamin C could reverse atherosclerosis. He was also a Canadian physician, and Linus Pauling was one of his buddies who talked about the benefits of vitamin C to deal with lipoprotein and to blunt lipid oxidation. So we included vitamin C, and he knew that B vitamins were often in short supply, and indeed they are, so we added in B vitamins and some minerals to come up with a Rinse morning feed. And he published this, and many people began to take Rinse's formula. Rinse's angina got better. These other chemists and biologists who hung around with Rinse began to take it and got better. And Rinse lived a long, healthy life. He died at age 92, and there's some controversy regarding his death. There have been rumors, something about a hotel room and a jealous husband. We don't know about that for sure. But anyways, the Rinse morning feed worked really well, but because it was not patentable, because it was not a drug, it never made it into American or European, for that matter, allopathic medicine. And our story would have been lost. However, chemists at Natterman AG, a German pharmaceutical company, looked at the Rinse formula and tried to make a patentable product that they could utilize as a drug. And what they did was they would distill soybean lecithin over and over again and draw off a fraction that was enriched in linoleic acid. And that is basically the material that we're using. They called it lipostabile or N-essential. We call it PPC, essential phospholipid, or plaque. It is a soybean-derived lecithin rich in linoleic acid. Now, there should be no soy protein in this. This is just the phosphatidylcholine. So if you're soy intolerant, it really shouldn't be a worry that you're taking phosphatidylcholine derived from soy. However, because of the issue of soy, some of the manufacturers, such as the manufacturer of Detox Max, and we'll talk about that a little bit later, are using sunflower oil as their source of phosphatidylcholine. So what we are using, lipostabile N-essential PPC plaque, is enriched with linoleic acid, particularly in the second carbon position. That is the fatty acid that LCAT uses to esterify cholesterol to carry out reverse cholesterol transport. So this was a drug in Europe, and I've read 500 papers or abstracts. I haven't read them all, but all the ones that are in English I've read on lipostabile. It was a best-selling drug for many, many years. And then it went off patent, and everyone forgot about it. So when if a substance is not profitable for a drug company, no TV ads, nothing in the newspaper, you forget about it. It never made it to the United States because our patent laws would not protect a drug made from a natural product. So it was never used in allopathic medicine in the United States, and everybody forgot about it until Sam Baxis, an internist in Switzerland, had a problem. His wife and his mother-in-law were suffering from recurrent coronary disease. The drugs weren't working. They weren't candidates for further revascularization. He had a big problem, and nobody could help him. But Dr. Baxis remembered from medical school that they talked about the use of lipostabile. So he calls up Natterman. They don't want to talk to him about it because it's off patent. So he gets the formula, takes it to a compounding pharmacist, and makes his own. And he treats his wife and his mother-in-law with intravenous PPC. And they both got better. And of course, he treated his mother-in-law first. Why did he treat his mother-in-law first instead of his wife? Well, that was because if something went wrong, there would be no great loss. So anyways, he began to use PPC in Switzerland to great advantage, and it sort of caught on again in Europe. Now, Dr. Baxis's daughter, Anita, emigrated to the United States. And she began to popularize the use of oral and IV PPC in cardiovascular disease. And her product goes under the trade name Plaquex. And we are using Plaquex. We can get this from other compounding pharmacies. We can also import it from Europe, although that's kind of cumbersome to do. So most of us are using PPC from Anidabaxis under the trade name of Plaquex. And this will work very well. Here's FJ, 65-year-old diabetic female with untreatable hyperlipidemia. This was before we had PCSK9 inhibitors. Her LDL's 220, 2 prior heart attacks. So in the 90s, she had 2 heart attacks and she had a 5-vessel bypass surgery. I met her in December of 94. I did a heart cath. 2 grafts are open, 3 are closed, advanced pump dysfunction, just barely compensated heart failure. Well, at this time, I was starting to hang around with Steve Sinatra, and I learned about coenzyme Q1 carnitine, and we began to apply the principles of integrative cardiology to help her make ATP in the mitochondria of her stressed heart. And she did okay for a few years and had angina in 99. Again, 2 grafts open, 3 closed. Her ejection fraction was 35 to 40%. It had gotten a little bit better with the integrative cardiology maneuvers. So we treated her with ECP to generate natural bypasses to promote collateralization, and her angina improved. Came back a few years later, we treated her with the Nanobac EDTA methodology, which is another approach to chelation therapy using suppositories, rectal suppositories of EDTA, and that gave her a good 6 years. Then she came back with angina. A dobutamine stress test was abnormal. I did another heart cath. 1 graft's open. Her ejection fraction is 20%. So we learned about intravenous phosphatidylcholine, and we treated her with 21 treatments. And she was also in the TAC study where she received placebo therapy. So basically, we added intravenous phosphatidylcholine to our prior best therapies in a patient with recurrent and inoperable coronary disease, and she did better with significant reduction in symptoms. Why? Because we're promoting reverse cholesterol transport. We're pulling cholesterol out of the artery wall, and we're improving cell membrane function, and we're improving the ability of red cells to migrate through the capillaries, and we're decreasing platelet aggregation. And we'll talk about all those physiologic benefits of PPC. But for this patient, it worked when no other options existed. So now we're going to talk about microspherical phosphatidylcholine. Now, the PPC that we take is a oily material. It's not that well absorbed. It is absorbed, and if you just take PPC as I do, I take 900 milligrams 3 times a day, enough is going to get in to favorably affect your physiology, but it is a fatty material and it's not that well absorbed. So what the nutraceutical manufacturers in the United States have done, they've taken this material, and what they do, they whip it at high speeds and they sonicate it. They bombard it with sound waves, and then the PPC will organize itself into these microspheres, kind of like a cell membrane, and you can admix EDTA and other bioactive substances. So the microspheres of the PPCA serve as a carrier vehicle to allow other molecules to hitchhike in the body. Now, if we treat you with oral EDTA, raw EDTA, maybe 2% gets absorbed. But if we mix it with the PPC microspheres, much more will get absorbed into your body. So per fluid ounce of this material, you get 15 grams of PPC, 500 milligrams of EDTA. They put in lipoic acid, which is a fat and water soluble antioxidant, and magnesium. So because the PPC is sonicated into the microspheres, this allows for rapid absorption of the circulation. The PPC will then be incorporated into lipoproteins and cell membranes, just as it is with oral PPC or IV PPC, and the EDTA, the lipoic acid, and magnesium hitchhike in the microspheres, so we get better absorption than we would if we just took the raw EDTA. So now we have a mechanism to give you PPC and chelation therapy in a single material. Now, why do we want to treat you with chelation therapy? Well, we have other presentations on chelation, extensive presentations, but in the trial that says chelation therapy, we took 1,500 people, they had a heart attack. We put them on drugs. They're all on statins. Their LDLs were low. Their sugars were under good control. and we treated them they put them into 1-4 groups, and then we followed them for 5 years. The worst outcome was in the double placebo group. The best outcome was the group that received 40 EDTA chelation treatments and a high potency vitamin and mineral. Why do we do that? Well, the whole point of this, as Dr. Chappell explained to me 25, 30 years ago, was that oxidative stress is the driving force underlying atherosclerosis. So if we give you antioxidants, we'll neutralize some of that oxidative stress. If we remove heavy metals, the cause of the lion's share of oxidative stress will lower free radicals. So of course, the best outcome occurred in the group that got EDTA and the high potency multivitamin. The groups that got EDTA alone or the multivitamin alone had an intermediate outcome. And of course, nothing happened for the first year. Why is that? Because it takes time to turn a ship around. But if we permanently remove metals from your body, we're going to permanently lower oxidative stress, permanently decrease your risk of recurrent heart attack, stroke, heart failure, the need for revascularization. The diabetics they benefited more than the non-diabetics. And here there's this dramatic reduction in event rate in the diabetics that receive chelation and the multivitamins. Why? Being diabetic, you become a free radical factory. So you're experiencing more oxidative stress than a non-diabetic. Thus, you have a greater upside potential of any antioxidant strategy. You're going to get more out of it. And by treating the diabetics with chelation therapy and multivitamins, we basically resolve the increased risk due to being diabetic. So the free radical stress associated with diabetes was negated when we treated you with a high-dose antioxidant vitamin program and chelation therapy. So if you got cardiovascular disease, I want to remove metals from your body. And if we use the microencapsulated PPC with EDTA, I'm getting reverse cholesterol transport, I'm getting improved cell membrane function, and I'm getting chelation therapy in a single material. If you have kidney disease, and we chelate you, we will stabilize your kidneys. The worse your kidney disease, the more sensitive you will be to the adverse effects of oxidative stress and heavy metals. Indeed, much of the kidney disease in the United States is due to heavy metal overload. Why? Well, heavy metal overload leads to high blood pressure leads to kidney disease. The kidneys are filtering the blood. Any metals in the blood will sequester in the kidney, causing oxidative stress and damage to the kidneys. 3 randomized double-blind studies have shown that chelation therapy has a stabilizing effect on declining kidney function. In this study, they had people with chronic kidney disease. They measured glomerular filtration rate, GFR, and that's an index of kidney function. Normal is 100. Mildly abnormal is 60. These people started at like 38, and over 1 year, they just followed them, and they're going downhill. So one group gets chelation therapy to remove lead and cadmium, and you can see that they stabilized, whereas the placebo group went downhill. Doubling of baseline serum creatinine as an adverse endpoint occurred in 27% of the placebo patients, only 5% of EDTA patients. They needed, less likely did they need dialysis or kidney transplantation. This has been shown to work in diabetics and non-diabetics, and someday chelation therapy will be covered by insurance, it'll be covered by Medicare, and we will dramatically decrease our need for dialysis, for antihypertensive therapy, and for invasive cardiovascular procedures. We're going to put this in the hands of primary care physicians so they can help prevent your need for dialysis and invasive cardiovascular procedures. And that's going to be 10 to 15 years from now, because the politics is against us, because nobody really wants to do away with the need for dialysis and drugs and invasive cardiology. Thus, there's great resistance against chelation therapy, but we have the science on our side, and eventually the government's going to wake up and say, yeah, we should cover chelation therapy so we can prevent cardiovascular disease and help prevent, or ameliorate at least, kidney disease. So that'll come in the future. So what we're using here is the Microspherical PPC EDTA, a half bottle or 6 teaspoons. I have people take typically a bottle a week, a half a bottle, 6 teaspoons twice a week. You get 15 grams of PPC, EDTA, lipoic acid, magnesium. We give you the PPC in a form that is well absorbed, and the other agents hitchhike in the microsphere. Thus, I may recommend that you take oral microspherical phosphatidylcholine mixed with EDTA in an effort to remove toxic metals from your physiology. Which metals will this preparation remove? What is the efficiency of oral chelation therapy utilizing this material in comparison to our other approaches to chelation therapy, such as with the use of intravenous EDTA? Well, to determine your soft tissue metal burden, we will administer to you a chelator, and then we'll record the amount of metal excreted in the urine over the subsequent 6 hours. And based upon the findings, I will recommend a chelation therapy protocol specific for your individual metal burden. If we're going to be comparing one chelator against another, we will carry out a baseline 24-hour urine, then we'll administer a chelator, and then we will obtain 24-hour urine specimens over the next 1 to 2 days and look at the relative increase in excretion of a given metal. This study was carried out by Arnold Takamoto of Bioimmune Inc., who formulates Detox Max, which is my favorite microspherical phosphatidylcholine EDTA preparation. So Arnold took a number of patients, did a baseline 24-hour urine, and recorded the amount of metals that were being excreted at baseline. Then he treated them with Detox Max and did 2 subsequent 24-hour urine collections, day 1 and day 2. And he found over day 1, aluminum excretion doubled and then it stopped. On day 1, arsenic increased 75%. On day 2, it rose nearly 15-fold. Cadmium, lead, and nickel were excreted day 1 and day 2. Same with tin. No mercury came out day 1, and then it tripled on day 2. Why the delay? Well, intravenous EDTA is a poor mercury chelator. Intravenous EDTA does not get into the cells, and it can't get at the mercury, which is bound to proteins within our cells. Well, our theory here is that the microspherical phosphatidylcholine not only does it enhance EDTA absorption from the GI tract, but the microspherical PPC is probably being incorporated into the cell membranes, and it's taking the EDTA into the cells where the mercury is. Thus, it's removing mercury. It takes a day for the EDTA to get into the cells, so that's why we don't see mercury excretion on day 1. We see mercury excretion on day 2. These numbers are quite impressive, but this doesn't mean that all the metal is going to be removed from your body instantly, because if your baseline urine metal levels are low, doubling it or tripling it or raising it tenfold doesn't mean that a whole lot of metal is coming out. But it does mean that we can carry out chelation therapy utilizing oral microspherical phosphatidylcholine EDTA. It will remove all the metals that are removed with intravenous EDTA, and it also appears to have unique efficacy with respect to mercury excretion. I read Arnold's study and I was intrigued, and I began to use Detox Max oral microspherical phosphatidylcholine mixed with EDTA in the treatment of my own patients who were troubled by atherosclerotic vascular disease and a heavy metal burden. Some therapies sound great in the literature, but they don't work out well in clinical practice. So, of course, I wanted to prove to myself that this approach would be of value in heavy metal detoxification, lipid panel improvement, and with respect to improving blood flow in my own personal patients. So I would evaluate the status of my patient before and after a course of treatment. Let's look at KL, 75-year-old retired gas station owner who presents with dizziness and a 60% narrowing in one of his carotid arteries. Now that 60% narrowing is not tight enough to retard blood flow, but we know that that 60% narrowing is soon going to be an 80% or 90% narrowing if we do not take corrective action. So we carried out an IV EDTA challenge study and showed a significant spill of lead, and this is expected. KL was a gas station owner. He worked predominantly when gasoline still had lead in it. We would expect KL to have a lead burden. So we treated him with Detox Max, 1 bottle a week over 20 weeks, and then repeated the challenge study. And we saw, as expected, a reduction in lead excretion. So his post-EDTA lead spill fell by 65%. His dizziness resolved. This may be because lead was poisoning enzymes in his brain that caused dizziness. It may be that we opened up the microcirculation and improved blood flow. We're not sure, but his dizziness resolved and he was pleased, and his HDL rose from 30 to 50. So reverse cholesterol transport was enhanced by the PPC, as we would expect. Well, this seemed to be a pretty good idea, so we treated him with 20 more models of Detox Max at a half dose over 40 weeks, and then repeated his challenge study. We see a further reduction in lead. It's now down by 76% in comparison to baseline. He feels well. I do a stress echo study, and I cannot bring out any coronary ischemia. You'll notice that we didn't see aluminum coming out early on, and we see aluminum coming out now. This doesn't mean that he was newly exposed to aluminum. It means that we removed a great deal of lead. EDTA will bind far more tightly to lead than it will to aluminum. Early on, we brought out only lead, not aluminum. As we remove all the lead, there's more spare capacity on the EDTA, so it'll go after secondary targets. So when we see a secondary metal come out, it means that chelation for our primary metal culprit has been successful. So in this gentleman, Detox Max improved his symptomatic status. It certainly decreased his lead burden, and it improved his lipid panel. JW, 56-year-old, who had a stent placed, we did a red cell metal assessment. Now, the red cell metal assessment is not a perfect indicator of body burden because it's influenced by dietary intake. So if you take in a lot of fish that has mercury, your red cell study will look worse than would a provocative challenge, which is our best indicator of your soft tissue metal burn. But anyways, he had a lot of mercury. He's above the 95th percentile. 11 bottles of Detox Max, we repeat it, the mercury went away. Now, some of that could have been dietary change, but some of it was probably effective mercury chelation with the Detox Max. This is not one of my patients, one of my colleagues. They did a provocative challenge with EDTA and DMSA. DMSA is an oral chelator more specific for mercury than is EDTA, and there's a high mercury spill. After 15 bottles of Detox Max, the same challenge, apples to apples, you can see that the mercury cleared. So we're showing that EDTA admixed with PPC in the Detox Max format, in the lipophosphatidylcholine EDTA format, will remove metals from your body. Not as quickly or as efficiently as IV chelation, but it will get the job done. So, what are the effects just of PPC? Not PPC mixed with EDTA, but just PPC from the European and the Russian literature. Angina frequency and severity, your need for nitro will decrease. You'll walk farther on the treadmill. Time to ST depression, that's the point where blood supply is inadequate and not supplying enough oxygen to meet the needs of the exercising heart muscle will increase. So your symptoms get better, your treadmill performance improves. If you have lower extremity vascular disease, your leg cramping, your intermittent claudication will decrease, you'll walk farther. If we're doing ultrasounds and looking at plaque volume in the carotid arteries or the femoral arteries, those are in the arteries in the thighs serving your legs, we see better blood flow and a lower plaque burden. We're getting reverse cholesterol transport. We're improving your anatomy. So if we treat you with PPC, what are the physiologic effects? Well, this material will be rapidly taken up and incorporated into the cell membranes and the membranes that surround the organelles within our cells and within lipid particles. So it goes into lipoproteins, particularly HDL. It goes into platelets, so they're less sticky. It goes into red cells, so they're more pliable. Endothelial cells, so the cells lining our artery, they will take this stuff up and cell membrane function will improve. Every cell in the body will take up PPC. And this increases the degree of unsaturation of cell wall lipoprotein and organelle membrane lipids and the phospholipid to cholesterol ratio. We want our cell membranes to be predominantly composed of unsaturated as opposed to saturated fatty acids. We want a high ratio of phospholipids to cholesterol. Then we have an elastic functional cell membrane. As we age, we lose phospholipids, we lose unsaturated fatty acids, we generate cholesterol and saturated fatty acids, the cell membranes don't work. We can rectify that and create a more youthful cell membrane, and thus a better functioning cell membrane if we treat you with PPC. So again, we have that lipid bilayer and it needs to be functional. And if we flood it with phosphatidylcholine, we're going to improve cell membrane function. So all the enzymes, all the pores, all the channels associated with the cell membrane are going to function better. PPC will lower your blood sugar. It's not insulin, but why will it do that? By improving cell membrane function, your insulin receptors function better. They do what they're supposed to do. They respond to insulin better, and your blood sugar will fall. Again, with the cell membrane, transporters, receptors, enzymes, all these functions will improve if we flood the system with unsaturated phosphatidylcholine. PPC, administered orally or IV, provides a favorable effect on the enzymes of lipolysis, vascular wall cholesterol deesterification, and reverse cholesterol transport. Recall that lipases and phospholipases break down triglyceride and phospholipids respectively. The lipase enzymes in the liver that will clear lipids from the circulation and take them into the liver are stimulated. Thus, PPC will improve your serum lipid panel. Conversely, lipases and phospholipases within the vascular wall, which will pull lipids from the circulation and put them into the vascular wall, are decreased. ACAT, which is acetyl-CoA acyltransferase, is the enzyme that will take oleic acid and tack it onto free cholesterol to make cholesterol oleate, which is the principal component of atheroma within the plaque. That enzyme is decreased. Cholesterol esterase, which will split cholesterol oleate into cholesterol and oleic acid, is increased, and then that free cholesterol will be re-acylated with linoleic acid by lesser than cholesterol acyltransferase within the HDL particle to form up cholesterol linolenate, which is then taken from the vascular wall back to the liver. That enzyme is increased. So PPC is going to lower your serum lipid levels. It will block incorporation of lipids into the vascular wall. It will block formation of cholesterol ester within the vascular wall. It will break down the cholesterol ester, which is the principal component of atheroma, and that free cholesterol will then be loaded up in the HDL to remove from the body via the liver. Again, we take in the lipoproteins, enzymes, lipases and phospholipases will break them down. They get incorporated into cholesterol ester. Well, the PPC blocks the enzymes that break down the lipids. They block the enzyme that makes cholesterol ester. They stimulate the enzymes that break down the cholesterol ester into free cholesterol, and then we load it up into the HDL, take it out through the liver. So what happens when we do this? Your cholesterol is going to fall, your LDL is going to fall, triglycerides fall, HDL will increase, and we'll talk about this in greater detail in the second presentation, but we lower oxidative stress and thus levels of oxidized LDL fall, insulin sensitivity improves, blood sugar falls because you're improving insulin receptor function, blood pressure is going to fall a little bit as well. Cell membrane and fluidity and function increase, arteries become more elastic, platelets are less sticky, blood viscosity falls, the ability to dissolve blood clots improves, microvascular flow through the capillaries will improve because the red cells are more deformable. They can wiggle through these tiny channels. Homocysteine falls. There's an antioxidant effect. We lower inflammation, and prostaglandin generation is improved. More of the vasodilating antiplatelet prostacyclin, less of the pro-inflammatory thromboxane. Let's talk a little about the chemistry of reverse cholesterol transport. How exactly does HDL work? Here, we're going to incubate crystalline cholesterol with HDL in a petri dish outside of the body environment. And you will see that the HDL particles will dissolve the crystalline cholesterol, and this will proceed in a dose-dependent fashion. Stated otherwise, the more HDL present, the more rapid and complete will be dissolution of crystalline cholesterol. This process is blocked by the application of heat, or if the proteolytic enzyme trypsin is added to the milieu. Heat will inactivate enzymes. Trypsin will degrade enzymes. Thus, For HDL to dissolve crystalline cholesterol, an enzyme is necessary, and we know that that is less than cholesterol acetyltransferase. This process is also blocked if you add in a phospholipase that would degrade phosphatidylcholine. This tells us that not only is enzyme activity necessary, a cofactor for the enzyme, and that would be phosphatidylcholine, is needed. So for HDL to dissolve crystalline cholesterol, we need enzyme activity, we need the cofactor phosphatidylcholine. Again, HDL-mediated cholesterol dissolution requires enzyme activity, LCAT, and phosphatidylcholine. You can add different quality phosphatidylcholine to the milieu, and if you utilize PPC, phosphatidylcholine rich in linoleic acid, there will be a dramatic acceleration of PPC, again in a dose-dependent fashion. The more HDL, the more PPC present, the more rapid and complete will be the dissolution of crystalline cholesterol. Now, this is occurring in a petri dish situation. I will present studies later on showing that PPC, serving as a cofactor for less than cholesterol acetyltransferase, will promote dissolution of cholesterol ester in the vascular wall, improving blood flow, attenuating symptoms, and even reversing anatomic vascular disease. Let's talk about the pharmacokinetics of PPC. What is the fate of PPC when it is administered intravenously or orally? Here we've got the HDL of the patient before we administer PPC. Following IV administration, 68% of the PPC goes into the HDL, 40 to 60% after oral intake. Every cell of the body is going to get PPC, but it goes first to where it's needed the most from our point of view into the HDL. So we're going to flood, so the resting HDL has the body's own phospholipids, which will be a function of your diet. If you're taking in a lot of unsaturated fatty acids, you're going to have healthful phospholipids. If you're taking in saturated fatty acids or trans fats, you're going to have dysfunctional phospholipids. In either way, there's some cholesterol, there's some cholesterol ester. If we flood the HDL with PPC, we will dramatically increase the ability of the HDL to take up free cholesterol from the vascular wall and esterify it with linolenic acid. Thus, we see enrichment of the HDL with cholesterol and cholesterol esters, so you're going to be taking it out of the artery wall. We're flooding the HDL particle with PPC to stimulate LCAT to remove a fatty acid from the second carbon position of phosphatidylcholine, and if we're using PPC, that'll be linoleic acid, which will then be tacked on to free cholesterol to form cholesterol linoleate, which is then loaded up in the HDL and cleared from the circulation via the liver. So we're going to be promoting reverse cholesterol transport, removing cholesterol from the vascular wall into the HDL and out and through the liver. So our focus in cardiovascular disease is to stimulate HDL-mediated reverse cholesterol transport. We're also going to be stimulating LCAT throughout the body. LCAT is present in the circulation, it's present in all of our cells, and when we administer PPC, we'll be promoting lipid exchange throughout the body. And thus, we're going to be improving cell membrane function within every cell in the body. If we improve the quality of the cell membrane in the red cell will be more elastic and pliable. It will be more effective at traversing capillaries. It will be more effective in delivering oxygen to our cells. If we improve the cell membrane function of the platelets are less sticky, they're less likely to aggregate as clots. Which phosphatidylcholine associated fatty acid would LCAT prefer to utilize to create cholesterol ester within the HDL particle to promote reverse cholesterol transport? Well, we know the answer to that question. It's linoleic acid. Phosphatidylcholine enriched in linoleic acid will maximally stimulate LCAT to generate cholesterol linolenate within the HDL to promote HDL-mediated reverse cholesterol transport. We know the answer to that question based upon this study. Here, you're going to incubate substrates, raw materials, cholesterol, and phosphatidylcholine molecules with varying fatty acid composition, along with the enzyme LCAT, and examine the reaction products, and that would be a cholesterol ester and phosphatidylcholine with 1 as opposed to 2 fatty acids, because one of the fatty acids was removed by LCAT to generate a cholesterol ester. And you will radiolabel the fatty acids, and then you can determine which fatty acids LCAT would preferentially utilize to esterify cholesterol. So the researchers incubated cholesterol with LCAT and phosphatidylcholines comprised of different fatty acids in their first and second carbon positions. And they demonstrated that LCAT prefers to utilize linoleic acid, particularly linoleic acid in the second carbon position of the phosphatidylcholine molecule. So with respect to stimulating LCAT activity, with respect to stimulating reverse cholesterol transport, linoleic acid is the most important fatty acid within a given phosphatidylcholine molecule. If you incubate cholesterol and LCAT with phosphatidylcholines containing saturated fatty acids, nothing happens. So we wish to use phosphatidylcholine enriched in linoleic acid. With respect to stimulating favorable lipase activity in other organs to help those organs remove lipids from the circulation and internalize them for proper use, PPC, phosphatidylcholine enriched in linoleic acid, is far more effective than would be other phosphatidylcholines, such as phosphatidylcholine obtained from egg or phosphatidylcholine obtained from an animal meat source, which would be rich in saturated fatty acids. Here we look at the activity, the activation of lipoprotein lipase to clear lipids from the circulation. It is maximally stimulated with PPC. Soybean lecithin is less effective. Many of you will go to the health food store and you'll be told, gee, you can just take soybean lecithin, you don't have to take PPC. That's wrong. Soybean lecithin is better than nothing, particularly if you mix it with safflower oil, kind of like to recreate the rinse formula, but soybean lecithin is not nearly as effective as PPC because PPC is enriched in linoleic acid. Soybean lecithin has some linoleic acid, but less than with PPC. Phosphatidylcholine obtained from egg yolk is far less effective. If you utilize a phosphatidylcholine containing trans fats, nothing happens. Thus, we wish to avoid trans fat intake. If we're interested in therapeutic lipid exchange and removing cholesterol from the artery wall, we're going to utilize PPC. Let's touch again on the physics of lipid dissolution. Butter, which is composed of saturated fatty acids, margarine, which is composed of trans fatty acids, and cholesterol will all be solid at room temperature. Oils, which are composed of unsaturated fatty acids, will be liquid at room temperature. The melting point of cholesterol is 300 degrees Fahrenheit. The melting point of a cholesterol that is esterified to a saturated fatty acid will be 180 degrees. So at body temperature, these will be solids. Cholesterol esterified with linoleic acid, its melting point is 32 degrees, thus it will be a liquid at body temperature. It is easier to mobilize a liquid than a solid from the artery wall. We've covered the physics and we've covered the biochemistry. We anticipate that PPC will not only remove cholesterol from the artery wall, we anticipate that PPC should have a favorable effect on our serum lipid panel. Let's take a look at the effects of PPC on the lipid panels of individuals with type 2 and type 4 hyperlipidemia. Type 2 hyperlipidemia refers to patients with an isolated elevation in LDL. Type 4 includes individuals with elevated LDLs and elevated triglyceride values. You do baseline lab studies, randomize the subjects to receive PPC 600 milligrams 3 times a day or matching placebo. You repeat the labs at 6 weeks. A double-blind protocol was followed. Stated otherwise, neither the subjects nor the researchers knew who was receiving PPC or who was receiving placebo. As you would expect, placebo therapy had little effect. With placebo therapy, cholesterol rose from 285 at baseline to 310 at 6 weeks. Conversely, in the patients receiving PPC, cholesterol fell from 309 at baseline to 269 at 2 weeks to 250 at 6 weeks. Likewise, LDL dropped from 192 to 131 at 6 weeks. HDL rose, triglycerides fell. Overall, with PPC, cholesterol dropped by 20%, LDL by 32%, HDL rose by 30%, triglycerides dropped by 30%. Why? The enzymes that clear lipids from the circulation were favorably stimulated. Jacobius Rinse got it right. So, PPC therapy lowers LDL and triglycerides and raises HDL. But would this work in other patient populations? Could PPC improve the lipid panel in patients undergoing dialysis? This is a group we'd really like to help because patients undergoing dialysis are experiencing a great deal of oxidative stress. Their LDL particles would become oxidized. Patients receiving dialysis are 20 times more likely than normal healthy individuals to experience a cardiovascular event. So here we're going to take 20 hyperlipidemic dialysis patients, hold their prior lipid-lowering therapies, carry out baseline lab studies, and randomize these patients to receive over 6 weeks 1,350 milligrams of PPC before breakfast and dinner or matching placebo. Repeat the lab studies over 8 weeks. Again, a double-blind protocol was followed. Cholesterol drops nicely with PPC. From 341 to 301, it rises slightly with placebo therapy. LDL falls, HDL rises, the ratio of LDL to HDL falls, triglycerides will fall as well. PPC has a favorable effect on the lipid panel in patients undergoing dialysis. We've established that PPC therapy will lower serum LDL. But what effect will PPC have on LDL oxidation? This is of critical importance because it is oxidized LDL, not native LDL, that initiates and drives the maladaptive response to the immune system characteristic of atherosclerosis. As your oxidized LDL level rises, so will your carotid artery intermediate thickness, and carotid IMT is our best surrogate marker for one's current propensity to form new plaque and to experience a future adverse event. From an epidemiologic perspective, if we look at your relative risk for experiencing a future cardiovascular event, being in the second or third tercile as opposed to being in the first tercile, the lowest tercile for a given lipid particle, yes, as your cholesterol and LDL levels rise, so does your risk. But if your oxidized LDL is elevated, your risk skyrockets. So will PPC have a favorable effect on LDL oxidation? Let's look at the effect of PPC on alcohol-induced LDL oxidation in the setting of experimental alcohol-induced liver disease. We're going to take 20 healthy adult baboons, place them on a basal diet that consists of 18% protein, 21% fat, 11% carbohydrate. They get some vitamin E and antioxidant in their water. We divide them into a control group whereby 50% of their additional calories comes from dietary carbohydrate, and an experimental alcoholic group where 50% of the calories are consumed in the form of alcohol, and this will produce alcoholic liver disease. Half in each group will also receive PPC, 2.8 grams per 1,000 calories every other day. And at 7 years, you evaluate their liver and LDL characteristics. Now, none of the baboons on the controlled diet that did not receive alcohol developed any liver disease. Of the alcoholic baboons, they all had fatty liver, whether they did or did not take PPC. If you are a chronic alcoholic, or you take in too much sugar, or if you take in too much high fructose corn syrup, you're going to experience fatty liver. Fatty liver by itself is relatively benign, but if the fatty liver progresses to cirrhosis, that can take your life. One of the 5 alcoholic baboons that did not receive PPC developed cirrhosis. 2 develop septal fibrosis, 2 perivenular fibrosis, mild or moderate fibrosis, a precursor to cirrhosis. None of the alcoholic baboons that took in PPC experienced cirrhosis or severe fibrosis. 3 demonstrated mild fibrosis. Thus, PPC will not protect you from fatty liver in the setting of chronic alcoholism, at least in this experimental model, but it will protect the liver, at least partially, from progression of fatty liver to severe fibrosis or cirrhosis. Now, lipid peroxides is a marker of oxidized LDL. So on the control diet, you have low levels. Control diet with PPC, you have low levels, actually slightly lower because PPC is an antioxidant. With alcoholic liver disease, you get a great deal of lipid oxidation. Lipid peroxides are high. All the cell membranes are going to be oxidized and dysfunctional. The high alcohol diet with PPC, you can see there's a dramatic protection against lipid oxidation. The lag time to copper-induced oxidation, here you take the LDLs, put them in a test tube, add in copper as a pro-oxidant, and see how quickly you can oxidize them. The control LDLs are relatively resistant to copper-induced oxidative stress. PPC, there was no significant effect. With alcohol, it's very easy to oxidize the LDL. Alcohol and PPC, there's some protection. How quickly an LDL will migrate in an electric field also is an index of how likely it is to become oxidized and get taken up by white cells to form foam cells to form plaque. It is highly mobile with alcohol, but if you add in PPC, this pro-atherosclerotic characteristic of LDL that is brought on by alcohol and oxidative stress is blunted. So PPC will lower oxidative stress. That's a very good thing. Now, diabetics are under a great deal of oxidative stress, as is everybody with atherosclerosis, but diabetics and dialysis patients even more. Will PPC work in lipid control in diabetics? 30 adult onset diabetics with hyperlipidemia, all with stable glucose values, off lipid-lowering therapy for at least 4 weeks. Do baseline studies, randomize them to receive 2,700 milligrams of PPC per day or matching placebo, measure lipid values periodically, and 4 weeks post-study, double-blind protocol followed. So with PPC, as you would expect, cholesterol falls, LDL falls, HDL rises, triglycerides fall. As you'd expect, PPC works. So far, PPC has worked in every population in which it has been studied. Fasting glucose fell slightly with placebo therapy. It fell just slightly with PPC, no major difference there, but 2-hour glucose, your ability to tolerate a glucose load was unchanged with placebo therapy, and it improved from 162 to 153 with PPC. Why? Because if we improve cell membrane function, the insulin receptor functions better, we get better insulin sensitivity. Now, if I give you a statin to lower your cholesterol, your blood sugar is going to go up. Statins raise blood sugar by causing some form of cell membrane dysfunction. And we're supposed to say, well, it doesn't really matter because it's so important that we lower your cholesterol. The fact that we're kind of rendering you pre-diabetic or diabetic, it doesn't count. Well, I don't think that's a good thing. But if we use PPC, we're going to lower your lipids and pull cholesterol out of the artery wall, which we don't do with statins, and we're going to improve insulin sensitivity. Now, there were no treatment-related side effects. When I use drugs to lower your cholesterol, you typically don't feel good, and half the time you have to stop them because you feel terrible. So here they looked at the effect of PPC on sense of well-being. In 2/3, the subject said, gee, I feel better. Only 7% said it made me feel poorly. With placebo therapy, nobody felt better. In fact, they felt worse because they were diabetics and they don't feel so good. But if you treat them with PPC, you feel better. Why? Not just because we're lowering your cholesterol, because we're improving cell membrane function. And by the way, some of that PPC is entering your brain to make acetylcholine so you can think better. Your memory will improve. We'll talk about that in the second presentation. So when we treat you with PPC, you tend to feel better because we're improving your physiology. If I give you a statin, you tend to feel worse because I'm actually poisoning your physiology. There's a time and a place for statins, of course, but they never make you feel better. PPC probably does more for you than a statin, and it makes you feel better because we're stimulating your normal healthy physiology. This is a man who really needed to have the remaining healthy aspects of his physiology stimulated. SR was a 47-year-old, 400-pound hypertensive smoker with sleep apnea, gout, and he bore mercury fillings. When SR was younger, he made moonshine whiskey. And when you make moonshine whiskey, in this process, you're exposed to a great deal of lead. There's a condition called Saturnine gout, which refers to gout on the basis of kidney disease due to lead overload incurred in the making of moonshine whiskey. SR presented in February of 1999 with heart failure, and as a result of the medications required to treat his heart failure, his kidneys were compromised, his butyl creatinine increased. I saw SR, we adjusted his meds, put him on a basic nutritional program. We kept SR out of heart failure. His kidney function improved. His creatinine fell to 1.4. Between 99 and 02, we adjusted SR's program. He was on maximally tolerated medical therapy. SR was a musician, but he was now blind. He could not work. His income was limited. SR could not afford all the nutritional supplements that I would typically recommend to a patient with SR's characteristics. So he was on a basic nutritional program, what he could afford. On this regimen, SR's glucose values were elevated between 200 and 400. Triglycerides are above 500 despite 400 units of insulin. Most diabetics require 20 to 40 units of insulin. SR required 400 units and it wasn't working. He remained hyperglycemic. He had severe diabetic neuropathy. He could feel nothing in his feet. His skin was abnormal. It was rough. It looked like alligator skin. And there were chronic boils and recurrent cellulitis. His joints were stiff. In 03, SR developed nephrotic syndrome as a consequence of chronic diabetes. His kidneys became leaky and protein spilled into his urine. In April of 03, we did a packed red cell metal study, which was all he could afford, and he did have metals in his red cells, and we were not surprised because he had mercury fillings, because he had been a moonshiner, and because we're all getting exposed to these toxins in our food and water in urban environment. So SR bears a metal burden, and we know that the oxidative stress generated by metals will drive diabetes, and we know that metals and diabetes will play a role in chronic kidney disease. Conversely, we know that removal of metals will lower oxidative stress and may improve one's kidney function. I was discussing SR's situation with Arnold Takamoto of Bioimmune, and Arnold kindly granted me the materials needed to treat SR. So in April of 03, we began SR on Detox Max, 6 teaspoons twice a week. That's a bottle a week. Fish oil. Arnold also has a vitamin C PPC preparation. He received that 1 teaspoon a day, and his other treatments were maintained for 2 months. Over this time period, many changes occurred in SR's physiology and overall health. His skin changed. Boils would erupt and this purulent, bloody material would drain out, and beneath that was smooth skin, so like SR was shedding his alligator skin. His sugars initially rose and then they fell. We hypothesized that this had to do with lead mobilization, some form of detox reaction. So his sugars went up and then they fell and his triglycerides fell. Insulin sensitivity improved. I got a phone call at 6:30 in the morning from the Academy of Medicine. It's SR. So I call SR. SR, what's the matter? Why are you calling? And he goes, doctor, I was taking a shower and I could feel the water on my feet for the first time in 10 years. And I said, well, that's nice, SR, but it's 6:30 in the morning. Well, Dr. Roberts, I thought you'd want to know. And his range of motion, his joints improved. His creatinine fell from 2.0 to 1.6, which is good. The degree of protein spillage, the degree of proteinuria decreased from 14 to 9 grams. His diuretic requirement was decreased. We were able to cut his insulin from 400 to 225 units, and his blood sugar was now around 200. This is SR's risk factor flow sheet. Triglycerides were chronically elevated, a peak value of 873 in August of 1998, 536 before 20 bottles of Detox Max. Following 20 bottles of Detox Max, insulin sensitivity had improved, thus triglycerides fell to 166. This is SR's baseline red cell toxic element study. This is the repeat evaluation following 20 bottles of Detox Max. We demonstrated that the Detox Max was clearing metals from SR's physiology, at least from the red cell compartment, and this coincided with SR's clinical improvement. Another patient, I talked about how metals play a role in high blood pressure and renal insufficiency, kidney insufficiency. Will Detox Max provide efficient chelation therapy to improve blood pressure control and improve kidney function? So RL, 70-year-old hypertensive man with mercury amalgam fillings, so I know he has a mercury burden. If you have mercury fillings, these are constantly off-gassing. With each breath you take, you're becoming more and more mercury toxic. If a dentist tells you that mercury fillings are safe, this is just basically not correct information. It is a one-way street. The mercury is going to be leaving your fillings and entering your body. Thus, if all things being equal, we want to get rid of your mercury fillings and then provide some sort of mercury chelation to protect you from the oxidative stress that's going to cause arterial disease, diabetes, high blood pressure, and kidney disease. So anyways, RL, in October of 2002, his blood pressure is 160 over 120. He has kidney dysfunction. His creatinine is 1.7. It should be 1.1, 1.2. So we put him on a bunch of medicines, a calcium blocker, a beta blocker, an ACE inhibitor, and a diuretic. So by 4 of 03, we get his blood pressure down to 160 over 80. His creatinine's a little bit better at 1.5. And we do an EDTA challenge, and we see he's got a lot of lead. And of course, we expected that. So we treat him with Detox Max, a quarter vial twice a week. We put him on nattokinase, which degrades fibrin and fibrinogen. It has a beneficial effect on arterial function. 8 bottles through 903. His blood pressure is better. We were able to stop his beta blocker. His creatinine fell to 1.3. His blood pressure got better. By removing metals, we were attenuating his hypertension and his kidney disease. We were able to back off on the medicines. You don't have high blood pressure because of medicine deficiency. You have high blood pressure because you've acquired toxins and other phenomena that cause oxidative and inflammatory stress. When you're 25, your blood pressure is normal. When you're 45, it's beginning to go up. When you're 55 and 65, it's up a lot. Why? Over the years, you've accumulated a toxic burden of metals and organic pollutants. You're probably also not exercising, and you probably put on weight, and those things all contribute. But if we can remove the metals, we can remove this key driving force that's causing high blood pressure and kidney disease, and we can do that with the Detox Max. We've established that metals play a role in arterial disease, hypertension, and kidney disease. Could toxic metals also play a role in idiopathic dilated cardiomyopathy? The answer is yes. Animal studies and epidemiologic studies in humans link cobalt, arsenic, lead, and cadmium and low selenium with cardiomyopathy. Why? These toxic metals poison enzyme systems. They cause oxidative stress. Toxic metals can displace nutritional metals, creating secondary selenium deficiency. The most egregious example of metal-induced cardiomyopathy has to do with dilated cardiomyopathy on the basis of ingestion of cobalt-tainted beer and leakage of cobalt from metal-on-metal artificial hips. If you go to a bar and you order a beer, you don't want it to look like this. You want to have the foam on top. That's the normal situation. And if you went to a bar 40 years ago, you would get beer with the foam on top. And the barkeep would then wash the glass with soap and water. It would dry, and then they'd pour more beer into it for that customer. That worked really well. Then commercial detergents were introduced, so they were using dishwashers in the bar, and the commercial detergents would leave a residue such that the foam wouldn't hold on top. You go to the bar and you get this, and that's not really very appetizing. It wasn't good for the beer business. So some bright guy in Canada found that if you add cobalt to the beer, the foam would come back. So they started manufacturing beer containing small amounts of cobalt. If you had a couple beers a day, it was no big deal. But the guys that worked in the breweries, they had free beer, so they would drink beer all day. They didn't eat a lot, so they would have like 12 to 18 beers a day, and they'd begin to die of cobalt cardiomyopathy because cobalt would damage the mitochondria. That's the fuel cell that generates all the energy, and their heart would be weak and flabby. They died of cardiomyopathy. And it took a long time to figure this out because initially it was felt that the problem was alcohol because excessive alcohol can cause cardiomyopathy. And then they saw that it was not just the alcohol, it was the cobalt. So they took the cobalt out of the beer and this problem went away. Now, if you have hip joint dysfunction, you may need an artificial hip. And this artificial hip can be made of ceramic or plastic or some sort of composite. The most durable hips will be metal on metal. There will be a ball and a cup of metal, and those artificial hips should last longer than plastic or ceramic or composite artificial hips. And they do. The problem is if the hip is not aligned correctly, there's going to be this grinding and this wear and tear, and cobalt will leave the artificial hip and stain your tissues throughout your body. And this is a disaster because by the time it is discovered, you are soaking with cobalt. So the therapy is to remove the artificial hip and then begin chelation therapy to remove the cobalt. But this is a slow and tedious process, and one's insurance company will not help. Somewhere, somehow, money exchange hands, and if you have cobalt cardiomyopathy on the basis of a cobalt-eluting hip, you are not subject to compensation from your insurance company. You're sort of disowned by the system, which is wrong. Anyways, I have two patients with cobalt cardiomyopathy. One is doing well, one is doing poorly because it's very difficult to remove the cobalt from the tissues. So metals do play a role in cardiomyopathy, and cobalt cardiomyopathy serves as the most egregious example. Cadmium plays a role. We obtain cadmium from tobacco. So in individuals who do not have cardiomyopathy, smokers have higher cadmium levels than non-smokers. People with cardiomyopathy are soaking with cadmium. Presumably they have a genetic abnormality that does not allow them to handle cadmium well, and individuals with cardiomyopathy, whether they're smokers or non-smokers, have high blood levels of cadmium. This study was done in Italy. They did heart muscle biopsies on people with cardiomyopathy and compared that to normal individuals or people who have pump dysfunction due to coronary disease, prior heart attack, or valve disease. And they found that the individuals with cardiomyopathy without an obvious cause were just soaking with metals. They had like 12,000 times as much mercury in their heart cells as did normal people. And the worse the pump dysfunction, the greater was the concentration of mercury and antimony in the heart muscle. This came from an autopsy series in North Carolina. They linked cause of death with tissue levels of lead and cadmium. And people with high lead levels tend to die of heart disease. The only people with low lead levels who did not die of heart disease had high cadmium levels. So cadmium and lead, oxidative stress, increase your risk of dying of heart disease. Yes, there's a link between metals, not just in arterial disease, high blood pressure, kidney disease. There's a link between metals and cardiomyopathy. WJ is a 78-year-old non-hypertensive, non-diabetic, amalgam-bearing, obese former smoker, so we know he's got some cadmium, we know he has some mercury. With only mild coronary disease, he had advanced lung disease from prior smoking, he had sleep apnea. He comes into the hospital in August of 2001 with atrial flutter and heart failure. Now, in atrial flutter, the atria are beating at 300 beats per minute. The AV node provides a brake. This patient had atrial flutter with 4-to-1 block. WJ had 2-to-1 block, so his heart's going at 150. The heart can't handle a heart rate of 150 long term. You're no longer able to keep up and generate energy. You would develop a rate-related cardiomyopathy. His left ventricle was dilated at 7.3 centimeters. The upper limit of normal is like 5.5. His ejection fraction, the percentage of blood that the heart ejects with each beat, is 25%. It should be 50%. EPSS is a echo marker of pump dysfunction. It should be 1.0. It was elevated. So this man had a cardiomyopathy precipitated by the atrial flutter. So we converted him to normal rhythm. He's on amiodarone. We put him on an ACE inhibitor, a vasodilator that is appropriate in cardiomyopathy, and his left ventricle gets a little bit better. The ejection fraction rises 25% to 40%. His left ventricle is a little bit smaller. So let's talk a little bit now about atrial arrhythmias, because many of you are troubled by atrial fib or atrial flutter. As you know, I spent a lot of time teaching the principles of integrative cardiology to younger doctors, and sometimes they want me to spend some time with them talking about standard cardiology. So we'll set up a time for us to go over these principles, and they will compensate me for my time. That makes sense. If they're going to get 2 hours of my time, they're going to pay me. And anyways, this very young doctor wanted to know about atrial arrhythmias. So we set up a phone consultation, and we both went to the same website so we could look at the arrhythmias on paper and talk about them. Anyways, the pacemaker for the heart is the SA node. It initiates the impulse that travels to the AV node, which is kind of like the brake, and then it travels to the ventricles. In atrial fib, the atria are beating like a sack of worms at about 600 to 700 beats per minute, and infrequently a beat will cross over the AV node, so that determines the ventricular response. If the brake is strong, you'll have atrial fib with a controlled heart rate, such as an older individual will have atrial fib with a heart rate of 80. Younger individuals don't have a strong braking function. They have atrial fib at a rate of 150. So what we do is we use drugs to increase the block, like a calcium blocker, digoxin, or beta blocker, to slow down the ventricular response to atrial fib, and then you will improve. In atrial flutter, the atria are beating in a regular fashion, but too fast at like 300. And if the brake is strong, you'll have 4-to-1 block, and you won't really notice anything. If you're younger and the brake is not strong, you may go to 2-to-1 block. So anyways, this is how we describe these atrial arrhythmias. So I spent a couple hours talking to this doctor, and then I think she understood the principles. And then I looked at my watch, it's 10:30 at night. We'd spent 2 hours talking about this, and I had to put an end to the call because I had to get up and go to work the next day. And you know, this doctor didn't offer to pay me a thing. She got 2 hours of my time to learn about atrial arrhythmias, and she didn't offer to pay me a thing. But on the other hand, when I taught her how to ride a bike, she didn't pay me either, so I thought that that was okay. Back to our man. So he comes in with cardiomyopathy due to atrial flutter, and we slowed down his heart rate, put him on an ACE inhibitor, and his ejection fraction improved, but it's still not normal. There was still something the matter with him, and we did a red cell element study, and we saw lead, and had we done a provocative challenge, we would have also seen cadmium, and we would have seen mercury. So therefore, it makes sense to treat him with chelation therapy. So he received 10 bottles of Detox Max, phosphatidylcholine mixed with EDTA, and after that, his ejection fraction normalized, his left ventricle is smaller, the EPSS echo measurement is now normal, and then he had 10 more bottles, and his heart's now looking normal. So he had a cardiomyopathy on the basis of metals, and the heart failure was precipitated by the atrial arrhythmia. So this was a good outcome, and this man never set foot again in the hospital for his heart. But he did have advanced lung disease, and I've now been working with him for about 18 years, and he called recently to cancel his visit. And my staff member asked, well, WJ, are you doing okay? What's the matter? Do you want to reschedule? And he goes, no, I don't want to reschedule. Well, why not? Well, because I'm going to be dead in 2 weeks. I'm in hospice, and they tell me my lungs are shot, I'm going to die, and I wanted to cancel my visit and thank all of you for helping me over these last 18 years. So my staff member immediately started crying. She told the rest of us. We started crying because we thought it was really considerate of this man to kind of call us and say goodbye. But we felt really good about our work with him because with chelation therapy and the other measures that we employed, his cardiomyopathy went away, and I think that gave him a good 18 years until he died at an advanced age of lung disease. Another case of using Detox Max in a patient with hypertension, kidney insufficiency, pump dysfunction due to coronary disease. So KZ is a 72-year-old hypertensive, non-diabetic, amalgam-bearing non-smoker, so he's got mercury, but he could also be exposed to lead and cadmium for the same reason the rest of us get exposed to lead and cadmium. It's in our food and it's our water. He comes into the hospital in January of 2002 with shortness of breath. He didn't have angina, but he had severe coronary disease with several heart attacks. As a result of the pump dysfunction, he had moderate mitral regurgitation. His ejection fraction was only 15%. And the contrast from the heart cath shut down his kidneys. He goes on dialysis. And he was too sick for bypass surgery. They said, you're going to be on dialysis the rest of your life. Well, he starts learning on his own about nutritional medicine. He starts taking many of the supplements that I would recommend to you, like coenzyme Q and carnitine and magnesium and all that. And his ejection fraction improves, and his kidneys improve, so they do a bypass on him. So I see him a year or so later. His creatinine's 2.8, normal's like 1.2. His blood pressure's high. He still has moderate mitral regurgitation. He has inflammation. His CRP is high. He had iron overload. Now, iron overload, reflected by high ferritin, also leads to oxidative stress and leads to cardiovascular disease and leads to diabetes. So if you have high ferritin, I'm going to recommend that you give blood to the Red Cross to get rid of it, and that will attenuate oxidative stress. So he had high ferritin, he had low HDL, his ejection fraction 30%, the EPSS is 1.6, normal's 1. He has an abnormal red cell element study. We put him on Detox Max, a quarter bottle twice a week. After 11 bottles, he's feeling great. He's chopping wood. His creatinine got better, a little bit better from 2.8 to 2.6. That's getting rid of the lead and cadmium. Blood pressure a little bit better. Mitral regurg is unchanged. His CRP, a marker of inflammation, fell from 7.7 to 3.7. Why? If we lower oxidative stress, we lower inflammatory stress and vice versa. We removed metals, we lowered oxidative stress, CRP fell, ferritin fell, because the EDTA will also remove iron, and his HDL got better, his ejection fraction got better. So by helping this man with the Detox Max, getting rid of the metals, you know, this man had had a series of heart attacks, he had a bypass, he had kidney dysfunction, he got better because one of the reasons he was sick was metal overload. We get rid of the metals, everything gets better. This was his red cell study beforehand, lots of lead and mercury. This is after, on all these parameters improved because we detoxified him. Let's talk about the effects of PPC on rheology. Rheology refers to the characteristics of red cell and platelet flow through our microcirculation. So here we have a capillary, the smallest blood vessel we have, and you can see these red cells wiggling through the capillary to get to your own cells to provide them with oxygen. If the red cell is pliable and wiggly and deformable, it can wiggle through these capillaries. If the red cell is stiff and rigid because its cell membrane is saturated with saturated fats and cholesterol, it won't work so well. Let's see what effect PPC has on rheology. Baseline studies, you do the erythrocyte sedimentation rate, which is an index of stickiness of red cells. You put some blood in a pipette and you see how quickly the red cells will coagulate. A correlate would be if you look at blood under the microscope, this is called rouleau. This is red cells clumping together because they're sticky. So you do the sed rate, and then you look at how quickly red cells will pass through an 8-micron filter, which is basically the size of a capillary. So the baseline studies, treat them all with intravenous PPC, 750 milligrams, a single dose, and repeat the baseline studies at 15, 30, and 45 minutes. So we're going to give you this IV PPC, and we assume that some of the PPC is going to enter your red cells and increase the content of phosphatidylcholine within the red cell membrane. Will this work? Sed rate falls 15, 30, and 45 minutes. So the blood cells are less likely to coagulate. The red cells are more likely to pass through a filter. More red cells are filtered. So this in vitro study shows that a single dose of PPC improves red cell rheology. When we treat you with PPC, your angina may get better fairly soon. Now, we're not going to be opening up your arteries in a couple weeks. That would be impossible. But if we're improving red cell rheology so the red cells can wiggle through the capillaries better and provide more oxygen to your cells, yeah, you would get better within a couple weeks. PPC and platelet aggregability. So when you form a clot, these platelets, the first thing, they clump together, they adhere to the artery wall, and that's the nidus upon which a fibrin clot, a scab, will develop. We do not want our platelets to demonstrate heightened aggregability. 31 hyperlipidemic subjects, baseline assessment of platelet aggregability. It's a horrible word to pronounce, the tendency of platelets to stick together. Treat them with PPC, 3,000 milligrams a day for 2 weeks, periodic reassessment. So nothing happened at 4 weeks, but at 8 weeks and 15 weeks, platelets were less likely to clump. So if you look at the platelets in an in vitro situation, at baseline, they clump together. Afterwards, they don't clump together. They're not as sticky. That is because platelets that are saturated with unsaturated phosphatidylcholine are less likely to stick together. Thus, we have an anti-platelet effect. The reason you take aspirin is to block platelet aggregability. PPC does the same thing by improving the platelet cell membrane function, enriching it with unsaturated phosphatidylcholine. Let's look at the ability of PPC to blunt statin-induced platelet dysfunction. Now, this is not a clinical trial that the drug reps are providing to us. We're going to take 18 patients with coronary disease and hyperlipidemia. At baseline, you measure lipid values and platelet function. Spontaneous platelet aggregation, is it likely to clump together to form a clot? Susceptibility of the platelets to ADP-induced aggregation. In a situation of energy failure, such as impaired oxygen delivery to the heart muscle, ATP cannot be recycled, and we have ADP, and ADP is released. That induces platelet aggregation. So if you're having a heart attack, you release the ADP, and your platelets are more likely to clot, and the amplitude of the aggregation response. So these are test tube in vitro indices of platelet function. You look at lipids, you put them all on a low cholesterol, low saturated diet plus lovastatin over 4 weeks. Now, lovastatin, the trade name is Mevacor. That was the first statin that was released approximately 32 years ago in my second year in private practice. Now, I knew about lovastatin because when I trained, we spent 2 weeks in a lipid research clinic, so I knew all about lovastatin. When it came out, I began to use it. And I received a lot of criticism from my colleagues for using lovastatin to treat only mild to moderate hyperlipidemia, and that was a cholesterol between 300 and 325. So back then, cholesterol 300, 325, we call that mild hyperlipidemia. But I used it because I had studied, and I knew that it was a good idea. And it's of interest that those same guys now are giving me a hard time for not putting everybody I see on high doses of statins. And of course, there's a role for statins. They do a lot of good, and they have some negative effects. They lower coenzyme Q, they lower testosterone. And this study will show that statin therapy, at least lovastatin, has an adverse effect on platelet function, and we'll see if we can rescue you with concomitant PPC supplementation. So low cholesterol, low saturated diet plus oral lovastatin, begin at 20 milligrams and go up to 80 milligrams a day as needed to get the cholesterol of the target below 200. Measure platelet function periodically. The percentage of platelets that form spontaneous aggregates increased. Wow. So cholesterol falls from 319 to 209, LDL from 227 to 132. That's desirable, but platelet aggregability increases. Spontaneous aggregates, susceptible to ADP, and increased aggregation amplitude. So the lovastatin, the Mevacor, lowered your LDL, what it's supposed to do, but as a side effect, your platelets were stickier. That's undesirable. Now, this doesn't make a lot of sense, because lowering the cholesterol to phospholipid ratio should have a beneficial effect on platelet function. Lowering cholesterol with lovastatin should have a beneficial effect on platelet function, but it didn't. Statin monotherapy has an adverse effect on platelet function, at least with lovastatin. Can PPC reverse this? So here, you're going to measure whole blood platelet aggregation rate, whole blood alone, and it was 16 units. That would be normal, or in the presence of lovastatin. So lovastatin causes the platelets to aggregate. Plasma from an untreated patient doesn't cause platelet aggregation. Plasma from a lovastatin treated patient does. So when you take lovastatin, there's a change in your serum such that it promotes platelet aggregation. But if you're taking lovastatin and PPC, that is negated. So actually your platelets are less likely to clump. So PPC has a beneficial effect on platelet aggregation, and it neutralizes the increased aggregation on the basis of lovastatin. Let's look at this from another angle. PPC versus lovastatin in platelet aggregation. 60 men, 36 years of age, with stable coronary disease. They had an LDL above 130 despite diet. And again, our target at that point would be an LDL of 100. With modern day drugs, our target would be an LDL below 70, all things being equal if you have cardiovascular disease. Baseline assessment, randomize them to a 16-week treatment protocol. One group received lovastatin and placebo. You start with lovastatin at 20 milligrams and increases needed to 40, aiming for an LDL below 130, so you're getting lovastatin and placebo for 8 weeks. Then you stop lovastatin, placebo therapy alone for 4 weeks, then you go back to lovastatin and placebo. The second group was lovastatin and PPC. Lovastatin 20, and you increase to 40 if needed to get the LDL to 130, and PPC, 900 milligrams twice for 8 weeks. Then PPC alone, then lovastatin and PPC. Repeat the baseline measurements at 8, 12, and 16 weeks. Double-blind protocol followed. So here's what in the black diamonds is lovastatin and placebo. So this is the run-in period. Cholesterol's high. If you give them lovastatin alone, cholesterol is going to fall at 4 to 8 weeks. And in the lovastatin placebo group, 70% required 40 milligrams of lovastatin. Then you stop lovastatin, cholesterol goes up again, you put them back on lovastatin, it falls again. Now, in the open inverted triangles is lovastatin and PPC. So with lovastatin and PPC, there's a synergy. Cholesterol falls further, and in this group, only 43% required the higher dose of lovastatin versus the placebo group. So you're using less lovastatin and you're synergizing with PPC, you get a greater fall in the cholesterol. And then when you stop lovastatin, the cholesterol goes up again, but not as much because you're still on PPC. Then you go back on PPC and lovastatin, and you get a better effect. So this is showing us that PPC lowers cholesterol, as we would expect. Lovastatin lowers cholesterol. Lovastatin and PPC synergize for a greater lipid-lowering effect. Well, what about platelet aggregation? So at baseline, platelets are not aggregating. But if you use lovastatin and placebo, or lovastatin and PPC, the platelets become stickier. But you'll see the group that got lovastatin and PPC, the platelets were less sticky than with lovastatin monotherapy. And then if you stop the lovastatin, platelet aggregation returns to normal, particularly in the group that got PPC, because PPC has an antiplatelet effect. Lovastatin causes platelet aggregation. PPC will attenuate the increased platelet aggregation effect of lovastatin. So PPC lovastatin interaction. PPC has independent cholesterol-lowering effects. PPC synergizes with lovastatin. PPC and lovastatin together, you get a lower cholesterol. That makes sense. PPC protects against the lovastatin-induced enhanced platelet aggregation. PPC lowered liver chemistries during lovastatin therapy. When we give you a statin, there's some low-level liver toxicity, and your liver chemistries will rise. As we'll discuss in the next presentation, PPC is great for anything the matter with your liver. So if you are on a statin and you have an elevation in liver chemistries, I add in PPC, I will lower your liver chemistries. Statin lipid-lowering therapy is best complemented by berberine. Now, when you take a statin and you lower the cholesterol content in the liver, you're going to make more LDL receptors. You're also going to make more HM-core reductase and more PCSK9. Berberine blunts PCSK9. Now, if you lower the cholesterol, you're going to start making more messenger RNA for the LDL receptor. Berberine stabilizes that, so you'll get a greater percentage of the RNA that is translated into protein, and berberine also improves insulin sensitivity. So if you're taking a statin, it's kind of dumb not to take berberine along with it, because it will undo many of the wrongs that statin therapy does, and it will synergize with the statin to lower your LDL. Statins lower coenzyme Q. We all understand that. My patients have been taking coenzyme Q for 25 years. That was a very, very good idea, because if we lower coenzyme Q, the heart cannot generate energy, your heart becomes stiff, and you might have shortness of breath that is neutralized with coenzyme Q. Statins will make LPA go up, which we can neutralize with lysine, proline, and vitamin C. It will lower testosterone in men. PPC will synergize with statins with respect to LDL, prevents the adverse platelet effects, and then PPC alone has multiple cardiovascular benefits. So if you take a statin, we're going to give you CoQ. If you're a man, we're going to pay attention to testosterone. We're going to pay attention to vitamin D. We're going to use berberine, and ideally, we will also utilize PPC. PPC and microcirculatory dynamics. 15 patients with coronary and/or cerebrovascular insufficiency. Treat them with IV PPC, 250 milligrams a day over 30 days. This would be how you would be treated in Europe or Russia. Study the effects on conjunctival microcirculation. So if you look at the blood vessels in your eye, this is sort of a mirror of the status of the blood vessels within your heart. And in Europe and Russia, they will do photomicrographs and study the conjunctival circulation. I have a handful of patients who live in Europe and Russia, and this is a routine test that they do. I don't know why we don't do it in the United States, but it seems like a really good idea. You look at the diameter of the arteries, the capillaries, the veins, the collaterals, red cell aggregation, blood viscosity, how thick the blood is, red cell deformability, can they wiggle through the capillaries, platelet aggregation, clot formation, and the ability of the serum to dissolve blood clots. So if we look at the conjunctival vasculature, arteries enlarge, veins enlarge, capillaries enlarge, collaterals form up, and platelets are less likely to aggregate with PPC. Platelet aggregation falls, its clot formation time is prolonged, it's more difficult to form a clot. The euglobulin lysis time refers to how quickly your serum will dissolve an exogenous clot. It is enhanced. Red cells are more deformable because they're enriched with phosphatidylcholine. They're more wiggly. Blood is less viscous. Blood is not syrupy. It's more like water than molasses with PPC. So PPC and microcirculatory dynamics, blood vessel dilatation, collateral vessel dilatation, platelet aggregation, clot formation are reduced, clot lysis, clot dissolution is enhanced, blood viscosity is reduced, red cell deformability is increased. PPC and blood flow rate in vascular patients. 20 patients with stable lower extremity vascular insufficiency symptoms. This is intermittent claudication. You're getting angina of the calf. You walk a certain level. Oxygen delivered to your muscles is not adequate, you hurt. That's the equivalent of having chest pain, angina, the same mechanism. And they had known blockages, abnormal angiograms. Measure rate of lower extremity blood flow at rest and with effort, brain blood flow, blood viscosity, before and after oral PPC, 600 milligrams 3 times a day over 30 days. And what they did, they would inject a radioisotope and see how quickly it would travel from point A to point B. And resting blood flow improved 13% in normals, 17% in those with mild to moderate vascular disease, 23% in those with severe vascular disease. Post-exercise blood flow also improved. So lower extremity blood flow through these narrowed arteries was improved with PPC. And this was only a 30-day trial, and the authors felt that they probably weren't opening up arteries. They might have been, but they feel that what they did, they improved rheology. Platelet and red cell membrane function improved, thus microcirculatory blood flow improved, the patients got better. And they looked at blood flow to the brain, and it was also improved. We all can benefit from more blood flow to our brains, particularly this man. SR is a 77-year-old overweight man with poorly controlled diabetes and liver disease. He was not my patient, he was a patient of one of my colleagues. In May of 2003, he presented with loss of vision in his right eye. He had had a stroke to the right eye due to carotid artery disease. His ultrasound showed severe disease in the right internal carotid artery and in the left internal carotid artery, so he was full with plaque. There was actually the right internal carotid artery was occluded. So he's not a candidate for surgery. He doesn't want to have surgery. He gets 24 vials of Detox Max and nattokinase, which we'll talk about a little bit later. It digests fibrin and fibrinogen. It can eat away at a clot. So after that, his vision was no better because he had had a stroke to the eye. The eye cells were lost, but they repeated the ultrasound. The left internal carotid artery had improved. The right internal carotid artery had opened up. There was only non-obstructive disease. So presumably he had an activated plaque with a clot, and the nattokinase digested the clot, and the Detox Max had a beneficial effect on arterial plaque formation. So that led to a study in our office. We took 6 of my own patients, comprehensive heart care patients, under treatment for symptomatic coronary disease. carotid artery disease of varying severity by ultrasound, and they're all on my standard therapies, antioxidants, essential fatty acids. We were dealing with homocysteine, lipoprotein, and lowering their cholesterol as best we could, and they all had prior special treatments. 2 had received intravenous EDTA. These were all patients with refractory coronary disease. 5 of the 6 had received external counterpulsation. That is our non-invasive approach to generate collateral flow. We have a separate DVD presentation on that. And 5 had received EDTA in the form of rectal suppository therapies aiming at nanobacteria. So these patients had received EDTA, they'd received ECP, they had advanced disease, and they were on all the therapies that I had to offer at the time. So we measured carotid artery flow velocities. We found a past study. We did a baseline study. We treated them with lumbrokinase 2-3 times a day for 4 weeks and 1-3 times a day to follow. Now we have a presentation on lumbrokinase. This is an enzyme released by earthworms to help them burrow through foliage. And this enzyme, lumbrokinase, will degrade fibrinogen, which is the precursor of fibrin clot. It will degrade fibrin, which is the scab that forms. If you have a clot, you have platelets that aggregate, and then fibrinogen is cleaved into fibrin to cause the scab. Lumbrokinase will digest fibrinogen and fibrin and will dissolve clots. So it's a very effective therapy in arterial disease. So we treated them with lumbrokinase and Detox Max, a half a bottle twice a week. For 20 weeks, we continued their same therapies, then we repeated the ultrasound. So this is RS. Now, the higher the velocity, the tighter the narrowing. Think about if you put your thumb over the nozzle on a garden hose. If you decrease the flow area, the velocity of water flow will increase. So as the percent stenosis, the percent narrowing of the carotid artery increases, you see an increase in velocity. So here in his right internal carotid artery, he had high systolic velocities and a moderate diastolic velocity. Then at baseline, it was 0 because he had had surgery. He had had a carotid endarterectomy. They scooped out the plaque. 5 months later into our program, there was no recurrence. His left internal carotid artery, the velocity had dropped a little bit from 110 to 89. With our prior best therapies, we had in the Detox Max, it falls to 67. MD had progressed a little bit in his right internal carotid artery. On the Detox Max and Lumbro, it falls. He also had had a carotid endarterectomy on the left. It fell from 302 to 44. It got a little bit better with our therapy. WT was worsening in both his right and his left internal carotid arteries, and there was regression of disease in both the right and the left. And there was stronger regression on the right. As a general rule, the tighter the narrowing, the greater is going to be your relative benefit of any therapy that I have to provide. PM had progressed slightly. He progressed slightly on the right. That was not significant. He had been progressing more rapidly on the left, and we had regression. This man had gone from 80 to 41 on his own, and he got just a little bit worse on the right. He had been progressing on the left, he got better. JW had been progressing in both the right and left, they got better. So adding in the Detox Max and the lumbrokinase to my prior best therapy had a net beneficial effect on carotid artery flow dynamics in a study that we did in the office on our own. And this would be similar to, we did not have a placebo group, of course, but we took a bunch of patients, we treated them, they got better, and that's consistent with my clinical observations. And we can use Detox Max and lumbrokinase as an alternative to your 16th stent placement. CJ came to me, he'd had 15 stents. And he didn't want to have a 16th stent. And his LDL was okay, but he had a high LPA, which we dealt with, high homocysteine we dealt with, low testosterone we dealt with. He had already had his amalgam fillings removed. And when I met him, we applied all the principles of integrative cardiology. He received ECP to generate collaterals, 21 IVD treatments, 15 PPC treatments. Then he got involved in a pilot study of magnetic sleep pad chelation. Static magnetic fields is a research interest of mine. I sleep on a negative field only magnetic sleep pad because that causes my electrons to spin and has increases energy generation throughout my body. And we feel that in a negative magnetic field, that energy that is added to your body will enhance detoxification. So he slept on a magnetic sleep pad. and we put him on antioxidants, minerals, and fish oils, and then he received microencapsulated PPC, that's Detox Max without the EDTA, every morning, and in the evening he got Detox Max 3 nights a week, alternating with more PPC the other nights, and he was on the sleep pad. We kept careful records of his clinical status, treadmill time, are you having angina, what's going on with your chemistries. And the Seattle Angina Questionnaire is an index of angina severity, and it improved. Carotid artery intima thickness, we'll talk more about that later, but carotid IMT is a surrogate measure of your tendency to form plaque. If your carotid IMT is progressing rapidly, that means you're forming plaque, you're going to get into trouble. If it's stable or it's regressing, that would be associated with a markedly decreased risk of an adverse event. And in just 6 months, his carotid IMT improved. So we're improving his biochemistry, reversing his predisposition to form plaque. Then we did formal carotid ultrasound. At baseline, he was 55% on the right. He got a little bit better to 49%. On the left, he was 38%, and there was no plaque at 6 months. And the vascular surgeon who's reading the studies called me. He goes, I can't believe this. It's not supposed to go away like that. And he goes, what are you doing? And I said, I'm removing the fuel and putting out the fire. The fuel is lipids. The fire is oxidative stress. So with the Detox Max and the Lumbro, we're lowering the lipids. We're pulling lipids out of the artery wall. We're attenuating oxidative stress. We're removing the fuel, putting out the fire, and he had anatomic disease regression. PPC effect in intermittent claudication. 808 subjects with symptomatic lower extremity vascular disease. Baseline clinical and treadmill assessment. Treated for 6 weeks with PPC. They called it EPL in that study. This was a European study. And then you reevaluate. Pain-free walking distance improved. There were 808 patients. 505 with rest pain reported complete relief. 198 with intermittent claudication reported complete relief. Only 105 of the 808 patients remained symptomatic. Mean pain-free walking time was improved from 9.8 to 21.3 minutes. A third showed improvement in their lower extremity Doppler studies, and they stressed long-term administration. Short-term therapy, you're going to get better, but if you want to get the job done, if you want to keep you feeling well, if you want to begin to reverse arterial disease, long-term therapy is appropriate. Here's one of my own patients, HD, 74-year-old hypertensive non-diabetic female with an elevated homocysteine, cholesterol 368, high lipoprotein A, high triglycerides, prior amalgam fillings. In 95, she had asymptomatic peripheral vascular disease. The ankle brachial ratio is the ratio of blood pressure in the arm to the calf. Normal is 1 because she had lower extremity vascular disease. Her ankle brachial ratios were low, 0.76 on the right, 0.71 on the left. Now, she becomes symptomatic a few years later. Even though I had her LDL down to 98 on a statin therapy, and even though I had her on a statin, the disease is worsening. The ankle brachial ratios are falling. We tried pentoxaline, which is an immune modulator and antiplatelet agent that we use. It didn't help. She's getting worse. We put her on arginine to improve nitric oxide generation, and that should improve lower extremity blood flow. She could not tolerate it. She stopped her statin due to the cost. Back in 2003, statins were rather expensive. At this point, I can't feel the pulses in her feet. So we put her on Detox Max, 6 bottles, claudication improved, 30 bottles, no claudication or cholesterol fell to 190. So we improved lower extremity blood flow. We improved the ability of red cells to flow through the capillaries. We lowered her cholesterol. We carried out reverse cholesterol transport, and she got better. These are ankle brachial ratios. You can see they're going downhill. We put her on the Detox Max, and they improved. So her symptoms improved. Lower extremity blood flow improved. We were quite pleased. Let's talk a little bit about PPC and the methyl cycle. The methyl cycle refers to the chemistry that allows us to shuttle methyl groups, carbon and 3 hydrogens, from one molecule to the other. 300 chemical reactions in our body depend upon proper methylation. Thus, the methyl cycle, you could think of it as the backbone of our biology. I've been very interested in the methyl cycle over the past 15 years. And in evaluating your methyl cycle dynamics, we do genomic testing, looking at the genetic status of these enzymes. We do nutritional testing, and we look at your toxic burden and take corrective action to optimize methylation, because 300 chemical reactions require proper methylation. PPC is important in that we generate phosphatidylcholine as a product of the methyl cycle. So if the methyl cycle is dysfunctional, you don't make phosphatidylcholine. Conversely, if we supplement you with PPC, we can improve methyl cycle dynamics irrespective of what the cause of methyl cycle dysfunction is. Now, we have an 8-hour presentation on the methyl cycle that I give to doctors. They complain it's too complicated. Well, you can complain that I'm too complicated, but don't complain to me. Complain to our creator or complain to Darwin. We are very, very complicated, but we need to understand how our physiology works so we can achieve optimal health and reverse any consequences of toxicity and nutritional deficiency. So you don't need to commit to memory all the things I say, and as you can tell, I'm repeating myself over and over so you can get the major points, but please indulge me and follow me a little bit about the methyl cycle, and if you're interested, you can look at our 8-hour presentation, which will be available next spring. I'll give you a case study of iatrogenic transatlantic methyl thievery. In other words, I made a mistake. I put a patient on drugs to lower their cholesterol that led to hyperhomocystinemia. Now, if your homocysteine is high, that means you're going to have a methylation impairment. SAMe, S-adenosylmethionine, is the universal methyl donor. It gives up a methyl group to create a useful product. You make S-adenosylhomocysteine that goes into homocysteine. When homocysteine is high, this process is stopped up and methylation ceases. So if you have a high homocysteine, that means you have methyl cycle dysfunction. So one measurement of your tendency to form atherosclerotic plaque is carotid artery intermediate thickness. We do an ultrasound of the carotid artery. We may see plaque, but our focus here is to look at the thickness of the artery wall in a normal section. This intermediate thickness, we use digital calipers, we can quantify it. We do 16 measurements and obtain an average. And the greater your IMT, the more likely you are to form atherosclerotic plaque. Now, IMT rises with age in ultra-healthy people, but the greater the number of risk factors you have for atherosclerosis, the greater will be your IMT, and the more likely will it rise with age. So we have data banks. We can look at your IMT in relation to your peers in your age group in the United States. Now, if you're at the 90th percentile, that means you are forming plaque at a rate that is greater than 19 out of 20 Americans. If you're at the 5th to 10th percentile, you're blessed. You're not forming plaque. Your risk of atherosclerosis and its complications is low, but if you have a high IMT, it means we've got a lot of work to do because you're going to get into trouble at some point. And we can predict risk based on your IMT. We can look at your 6-year risk if you're between 45 and 64, if you're above 65. The greater your IMT, the greater your propensity to form atherosclerotic plaque, the greater is your risk. Even more important is the rate of change of IMT. This study was done on individuals who had bypass surgery before the age of 50, obviously a high-risk group, and they did IMT studies on them over the following 9 years. Those whose IMTs were stable or progressing minimally did very, very well. Those whose IMTs were progressing rapidly had a greater event risk, as you would anticipate, because their tendency to form plaque was not attenuated. So looking at your IMT and looking at the effect our interventions have on IMT progression is very important to me. So DS was a dentist, had hyperlipidemia and mercury exposure. We lowered his cholesterol, we got rid of the mercury, his IMT steadily improved. KH has Lyme, and Lyme will wax and wane, and we found that when his Lyme was active, when he had all this inflammation, oxidative stress, his IMTs would be high. Then when his Lyme quieted down, they would get better. JS had 2 open heart surgeries. She had inoperable heart disease. I've been working with her for 10 years. Between 08 and 09, she worsened because it takes time to turn a ship around, of course, and then she got better. Then we got complacent, and she was doing well, and we lightened up on our therapies, and she worsened. We got to work again, and she got better. DB was a young man who had an executive physical, and he passed it. He did great. And he goes, I want more information. So we had a calcium score, it was abnormal. And that led to a heart cath, and one artery was closed. The other arteries were okay because he was athletic. He had no symptoms. So the stress test was not misleading. He was not ischemic because of the collaterals. However, he did have atherosclerosis. So he became very, very involved in understanding atherosclerosis and dealing with it. And he came to see me. And between our first year, he got worse because it takes time to turn a ship around. And then he got better again until he got worse. Now, this DB is David Bobbitt, and who is the best patient in the world. He runs a multinational out of Dublin, and he comes to the United States 4 times a year. I like to say he comes to the United States to see me, but he's here on business, and he sees me periodically, and he sees other doctors as well. He's learning as much as he can about atherosclerosis because he knows that his health is his personal responsibility. He's trim, he's athletic, but he did have risk factors for heart disease, and he's doing everything he can to attenuate them. And so his IMT increased, and then it got better, and then it got worse. What's going on here? This man is hyper compliant. In fact, when I see him, I want to tell him about something that I just read. He scoops me because he's read about this as well. Now, he really wanted to lower his LDL particle number. The target is 1,000 for prevention, maybe 700 would be optimal. He really wants to bring it down. So he was on a number of drugs to lower his LDL, and we achieved that. And despite that, his IMT got worse. So this didn't make any sense. So I had to analyze his chart and his history, and obviously I was doing something wrong. I saw that I was practicing brain-in-the-box lipid control. Now, I'm not supposed to be doing that, but I did. I made a mistake, and of course, we make mistakes, we learn from our mistakes. I had him on a statin. Well, I know that statins lead to coenzyme Q depletion, so I had him on CoQ. I know that statins lower testosterone, that leads to inflammation. I had him on testosterone. I also had him on niacin, and niacin depletes B6. The downside of niacin, it depletes B6, makes your homocysteine go up. The older studies of niacin looked really good. The modern day studies don't look so good, probably because they're not taking into consideration niacin-induced B6 depletion. Our diets are lower in B6 now than they were 25 years ago. I think if we repeated the niacin studies and paid careful attention to B6 and homocysteine, we would show that niacin works better. So when I treat people with niacin, I should put you on B6, but I didn't have DB on extra B6. Fenofibrate is a drug that lowers triglycerides, and it depletes trimethylglycine, which is a key cofactor in the methylation of homocysteine back to methionine. So by knocking out trimethylglycine and B6, I was knocking out 3 key enzymes involved in homocysteine metabolism. Now, this was really dumb because I know better, but I made this mistake. We were focusing too much on using drugs to lower his lipids. We forgot that every drug, even nutraceuticals, have potential downsides, and I had not taken corrective action. So we learned from our mistake, and we started to deal with homocysteine. Now, early on, he had a high homocysteine, and then we began to treat him, and then we got lax. I let his homocysteine go up. So even though I had his cholesterol down, his atherosclerosis got worse because I had knocked down 300 key chemical reactions. So we took corrective action. He's getting better again. Now, DB is a wonderful guy, and his interest is early detection of cardiovascular disease. He points out that half the people who die of cardiovascular disease, death is their initial symptom. You just drop dead. And so he feels everybody should get a calcium score and again, if you have a high calcium score, that doesn't mean you have to have a heart cath and a bypass, but it means you have atherosclerosis, and it really will motivate you into changing your behavior. If I say, gee, your carotid IMT is high, your cholesterol is high, that doesn't scare you. That doesn't cause you to change your behavior. But when we say, gee, you have coronary calcification, everybody gets kind of terrified and you get motivated. So he founded the Irish Heart Disease Association, and he produced a movie called Widowmaker. Widowmaker the movie. Go to widowmakerthemovie.com to see the movie. And then we talk more about this in our methyl cycle presentation. But the point here is I can lower your cholesterol all I want, but if I don't pay attention to other risk factors like homocysteine, you're going to get into trouble. And as you're going to see, methyl cycle dysfunction compromises the generation of phosphatidylcholine. Conversely, if I treat you with PPC, I can improve methyl cycle dynamics. So an overview of the methyl cycle. This has to do with using folic acid as a shuttle for methyl groups. This is folic acid. This is tetrahydrofolate. This is 5,10-methylene tetrahydrofolate. This is 5-methylfolate. So folates in our diet exist as polyglutamates. We convert them to a folate monoglutamate. They're absorbed, and then an enzyme called dihydrofolate reductase converts dihydrofolate to tetrahydrofolate. So tetrahydrofolate is the key raw material. An enzyme called serine hydroxymethyltransferase takes a methyl group from the amino acid serine, and it needs B6, and if that occurs, you make 5,10-methylene tetrahydrofolate. 5,10-methylene tetrahydrofolate can be diverted to form DNA and RNA to prevent malignancy, or the enzyme MTHFR, which is 5,10-methylene tetrahydrofolate reductase, converts 5,10-THF into methylfolate. Those of you who have what are described as MTHFR downregulations, that enzyme is sluggish and is not efficient in the generation of methylfolate. Now, I am homozygous for MTHFR. 10% of us are homozygous for MTHFR, so that enzyme doesn't work well. And that is actually a blessing. These are not mutations. These are variations in Mother Nature's plan for us, because if I eat and live the way Mother Nature intended, if I take in plenty of folic acid and B vitamins, and I do, I'm a 95% vegetarian, so I'm getting plenty of methyl donors. If I do that, my risk of colorectal cancer is 23% that of everybody else, because this is not a defect. It basically shunts methyl groups to make DNA and RNA. However, if I take a bunch of drugs to deplete methyl groups, if I drink too much, if I don't get phosphatidylcholine, I don't have methyl donors, then I will have methyl cycle dysfunction and I'll have a problem. Now, so during my gestation, my mother ate correctly. She didn't drink alcohol. She had plenty of green leafy vegetables. She was well nourished. So I had methyl donors. So I made it through gestation. But soon after that, I'm 63. And back then, we all ate healthy food. But beginning 40, 50 years ago, we started eating processed foods. There was more toxicity in the environment. There's more cadmium. There's more lead. There's more anti-folate drugs. Anyways, so if you had this genetic situation and your mom did not eat correctly, you didn't make it through gestation. You were miscarried. Now, we learned about this, and this is why women now take B vitamin supplements, because to deal with 10% of us that are downregulated for MTHFR. But if we eat and live correctly, we're okay. Now, this MTHFR enzyme that I've got doesn't bind tightly to its riboflavin-based cofactor. But people with MTHFR abnormalities who have adequate riboflavin, they have normal homocysteine. So again, many people say, gee, this is why I'm sick. It's not that big a deal, but it's part of the big deal of the methyl cycle that we want to analyze. So anyways, MTHFR converts folates to methylfolate. An enzyme called MTR uses methylfolate in the presence of methyl B12 to remethylate homocysteine back to methionine. BHMT, which is zinc dependent, uses trimethylglycine to remethylate homocysteine to methionine. We make SAMe, we use it, we make homocysteine, we need to recycle it. Some of the homocysteine is broken down the cystathionine beta synthase pathway to make antioxidants like glutathione, cysteine, and taurine. So during health, when we have a good diet, we're free of toxins, the methyl cycle functions well, and 300 chemical reactions that depend upon methylation proceed smoothly. If we're toxic, if I give you drugs that deplete nutritionals, if we don't follow a good diet, we have methyl cycle dysfunction. So 300 chemical reactions require methylation, including silencing oncogenes. So you have a high homocysteine, you cannot silence oncogenes. That dramatically increases your risk of cancer. Breaking down adrenaline, if you have hypertension, if you have white coat hypertension, if you do not recover from stress well because you can't break down catecholamines, adrenalines, that's because you have a methyl cycle problem. So the function of the methyl cycle is to maintain appropriate levels of pyrimidine and purine bases for DNA and RNA, antioxidant detox molecules such as glutathione, cysteine, taurine, and sulfate. BH4 is tetrahydrobiopterin. That is the key cofactor that we need to make nitric oxide and to convert raw materials such as tryptophan and tyrosine into neurotransmitters such as dopamine and serotonin. Without that, you're going to become depressed. And then transferable methyl groups. We need adequate production of SAMe and low levels of SAH, S-adenosine homethionine, we'll call that SALI. It is the ratio of SAMe to SALI that determines your ability to methylate. So pyrimidine and purine bases for DNA and RNA synthesis. So you have a methyl cycle dysfunction, you can't repair and generate DNA, it increases your risk of cancer. We make antioxidant and detox molecules, glutathione, cysteine, taurine, and sulfate as a product of the methyl cycle. BH4 is tetrahydrobiopterin. Without BH4, we don't make nitric oxide, we're going to have cardiovascular disease. Without BH4, we can't make neurotransmitters, we have down mood and depression. Now, methylfolate looks an awful lot like BH4. So high-dose methylfolate will substitute for BH4. And if you have endothelial dysfunction, if you have depression, we might treat you with high-dose methylfolate as a BH4 surrogate. And transferable methyl groups. 300 chemical reactions depend upon a high SAMe to SALI ratio. Now, so you need both BH4 and SAMe to convert raw material amino acids into neurotransmitters. So when the methyl cycle is dysfunctional, you're going to be depressed. You'll have enough raw materials, but the enzymes don't work because you don't have any SAMe, you don't have any BH4. So what we can do, we will correct all this, and then we can treat you with SAMe. We can treat you, we can't get BH4 in the United States. You can in Europe, but we can use high-dose methylfolate to act like BH4, and that will improve not just endothelial function, but will improve depression. Many different disease states will benefit from SAMe because 300 chemical reactions depend upon SAMe. You can use SAMe to treat depression. You can use SAMe to treat lead toxicity because you're going to make glutathione. You can use SAMe to treat osteoarthritis because synthesis of cartilage depends upon adequate methylation. So it's critically important. Now, the agouti mouse model is used in methyl cycle research. The agouti mouse is genomically sensitive to impaired methylation. And if you have impaired methylation during gestation, the mouse is yellow as opposed to the normal dark. So it's very useful in methyl cycle research, particularly in looking at the effects of toxicity and malnutrition during gestation on the health of our kids. We are experiencing autism at an epidemic rate. When I was a kid, I'm 63, when I was in grade school, there was no autism. Now, autism was quite prevalent. By 2050, we're going to have a 50% rate of autism if we don't take corrective action. And much of the damage is occurring in utero due to methyl cycle dysfunction, so the agouti mouse is a good animal model. Now, I give an 8-hour presentation on this to my colleagues, and these are long, tedious discussions, so I have to have jokes and skits. So I was giving a talk on the methyl cycle in Plymouth, Michigan at the Inn of St. John's, and my colleague and good friend, R.H. Poling, was there taking notes and diligently listening to what I had to say. So we're approaching the lunch break, so I pulled Dr. Poling up out of the group. He doesn't really know what's going on. And I suggested to the crowd that Dr. Poling and I had just returned from Stockholm, where Dr. Poling had received a Lifetime Achievement Award for coming up with the agouti mouse model. So we had our agouti Mouseketeer t-shirts and our agouti mouse hats. There's little mice on our hats there. So we had a good laugh about that. So it's lunchtime, and the lunchroom is on the other side of the complex. The Inn at St. John's is an old monastery, and we're giving this talk in the sanctuary, which is pretty cool. They have a lot of smaller sanctuaries and chapels, so it's a great wedding destination. So that weekend, it was a Saturday, there were 3 weddings going on. So there's all these young people dressed to the nines, sipping cocktails in the hotel lobby. So Dr. Poling and I, wearing our agouti mouse hats, lead 100 blurry-eyed doctors through the lobby amongst all these young people all dressed up, and they kind of looked at us like we're the Pied Pipers of Hamelin. We had an awful lot of fun that day because we can inject some fun into science. Of course, they have not asked Dr. Poling and I back, so maybe the joke didn't go over all that well. Maybe it. Anyways, One of the roles of SAMe is to generate phosphatidylcholine. So if you have a methyl cycle dysfunction, you're not going to make phosphatidylcholine. And if you don't make phosphatidylcholine, you're going to have cell membrane dysfunction. You're going to have impaired reverse cholesterol transport. You're going to have trouble making acetylcholine, the neurotransmitter for your brain. You're going to have a whole lot of trouble. How does this work? So we make phosphatidylcholine from a raw material called phosphoethanolamine, and then we methylate it 3 times. So we use 3 SAMes to make phosphatidylcholine. And we need phosphatidylcholine for cell membrane function, lipid metabolism, and acetylcholine. Now, we spend our SAMe on 300 critical chemical reactions, including breaking down adrenalins, metabolizing estrogens, silencing oncogenes. But we actually spend 2/3 of our SAMe on housekeeping chores, making phosphatidylcholine and creatine for muscles. So if you have a methyl cycle problem, and you're spending all your SAMe, and you're creating Sally and homocysteine you can't methylate, if we supplement with phosphatidylcholine and creatine, you don't have to spend the SAMe making phosphatidylcholine and creatine. You don't make Sally, you don't make homocysteine, and then you have an adequate SAMe to Sally ratio to carry out these critical reactions. So if you have a methyl cycle problem, I will treat you with phosphatidylcholine, I will treat you with creatine, so you don't have to spend your SAMe on housekeeping. Here's a patient who had a very low level of SAMe, a high level of Sally, high homocysteine. And this was a physician actually, and she was having trouble with her thought processes. So what we did, we treated her with phosphatidylcholine, we treated her with creatinine, and B vitamins to improve homocysteine remethylation. And you can see that all these values improved. Here was a 60-year-old woman with a structurally normal heart and atrial fib. And my hypothesis was she had a methyl cycle defect. She could not methylate catecholamine, so she could not break down her adrenalins, thus she had atrial fib. And she also had a mercury problem. So mercury will poison all the enzymes of the methyl cycle. So we dealt with mercury, we treated with phosphatidylcholine, we treated with B vitamins, creatinine, and the situation normalized. We stopped her antiarrhythmic drugs, no more atrial fib. Her atrial fib was not due to anatomic heart disease, it was due to impaired methylation on the basis of disturbed methyl cycle physiology. We corrected it, no more atrial fib. That was pretty cool. So we need a high ratio of SAMe to Sally to methylate catecholamines. That was thrown off by B vitamin deficiency, by mercury. We corrected that, and everything rectifies. PC, phosphatidylcholine, is generated by the methyl cycle. PC stimulates homocysteine recycling. Now, if we take phosphatidylcholine, it can be converted to choline, which is converted to TMG, which will promote remethylation of homocysteine back into methionine. The enzyme beta-hydroxymethyltransferase uses TMG derived from phosphatidylcholine to remethylate homocysteine. So any phosphatidylcholine will remethylate homocysteine methionine. Phosphatidylcholine spares SAMe, less Sally, the SAMe to Sally ratio increases. We're going to improve the methyl cycle. So we can use any sort of phosphatidylcholine for this purpose, but we're going to use PPC, polyenylphosphatidylcholine, because we want to improve the methyl cycle and we want to improve reverse cholesterol transport. So here's a clinical trial, phosphatidylcholine and homocysteine, 48 healthy men, none taking B vitamins, phosphatidylcholine, choline, or betaine, that's trimethylglycine, none with homocysteine above 26. They still had moderate elevations. We're going to study the 26 to 48 with the homocysteine that was elevated between 11 and 23. 11 is normal. Their mean homocysteine is 14.7. Baseline measurements randomized to receive over 2 weeks a high dose of PPC, 34 grams daily, or a placebo oil with the same fatty acid composition, but it wasn't as PPC. Repeat baseline measurements, cross over to the opposite regimen after 2-week washout. Double-blind protocol followed. Fasting homocysteine does not change with placebo therapy. It falls with PPC from 15.6 to 13.6. Homocysteine will rise after a protein load full of methionine. There was no effective placebo therapy. There was an improvement with PPC. So this proves what we would expect biochemically, that PPC supplementation lowers homocysteine. It improves the SAMe to Sally ratio. So we've touched upon the methyl cycle, and we now understand that phosphatidylcholine is a product of the methyl cycle, and that phosphatidylcholine supplementation will correct any pre-existent methyl cycle disorder. And that's very important in cardiovascular disease and in disease in general. Now let's get back to atherosclerosis, our focus with this presentation. And recall I stated that atherosclerosis can be considered to be a maladaptive response to the immune system to what it perceives as infection of the artery wall with oxidized lipids. We need hyperlipidemia, we need immune dysregulation. And this is an animal study that seeks to recreate that pathophysiology, and we'll see if PPC will have an ameliorative effect. So here we're going to take 2-year-old male baboons, cute little guys. Their biological name is Papiocyanocephalus. And you're going to feed them over 6 months a standard baboon chow diet, a control diet, or a diet designed to produce atherosclerosis, an atherogenic diet with egg yolk and butter. Okay, so 3 months into this, you're going to administer intravenous saline. That's the control group. Another group gets intravenous bovine serum albumin every 2 weeks by 3 injections. Now this is not a normal molecule for the baboons, and it creates an autoimmune response. So you've got hyperlipidemia and you've got autoimmune injury and inflammation. And then you create this autoimmune model and then treat the animals with saline as a control or intravenous PPC 1,000 milligrams 3 times a week, a dose similar to what we would treat a human with. Sacrifice all at 6 months and evaluate aortic wall, biology, and lab studies. So what you see, serum cholesterol on the control diet is normal. If you go on the control diet and the immune stimulation, nothing happens. On the atherogenic diet, cholesterol is high. If you add in immune stimulation, nothing happens. That was not a statistically significant reduction in cholesterol. But on the bad diet, plus 3 months of PPC, there's a reduction in cholesterol as you would expect because PPC will lower your cholesterol. But we're not really interested in your cholesterol. We're interested in atherosclerosis and plaque. So here, on the control diet, there's no plaque. With immune stimulation, there's no plaque. On the high cholesterol diet, there's no plaque. But the high cholesterol diet and induced immune dysregulation, you're loaded with plaque. The bad diet and immune stimulation, modeling human atherosclerosis plus PPC, there's much less plaque. So we're lowering cholesterol a little bit, but we're blunting plaque deposition a great deal. Why is this occurring? Well, let's look at enzymes. I mean, that was Dr. Rinse's hypothesis that cholesterol was not the problem, but the enzymes that control cholesterol metabolism were dysfunctional. So aortic lipase will break lipid particles down such that they can be incorporated into cholesterol esters within the artery wall. And that is stimulated by the bad diet and immune stimulation. If you add in PPC, aortic lipase, which will break the lipid particles down into subunits that can be incorporated into the vascular wall, is inhibited. Aortic cholesterol esterase that breaks down cholesterol oleate, which is atheroma, is inhibited by the bad diet, but the bad diet and immune stimulation in PPC, we pick it up. So PPC stimulates the degradation of cholesterol oleate back into free cholesterol that can be loaded up into the HDL and removed from the artery wall. Thus, this basically shows us that Rinse is correct. It's not just the cholesterol, it's not just the immune dysregulation. The combination leads to atherosclerosis, and if we add in PPC, we lower the cholesterol a little bit, but we affect enzymes such that the lipids don't enter the artery wall, the cholesterol is not esterified, you break down the cholesterol esters, and then HDL will load up the cholesterol that is now esterified as linoleic acid, take it out through the liver. Again, we stimulate reverse cholesterol transport. Of course, we don't want a high LDL. The more LDL that is present in the circulation in association with a high saturated fat diet, you're going to get more atheroma. But what we're interested in is stimulating HDL, stimulating LCAT with HDL, and blocking the generation of cholesterol esters, supporting the degradation of cholesterol esters. Then the free cholesterol will be acted upon by LCAT. You'll form cholesterol linolenate, and then it loads up to the HDL and you take out through the liver. Another animal model, they take quail, feed all the birds an atherogenic diet for 3 months, sacrifice a third, and assess the severity of vascular atherosclerosis on a 0 to 100 scale. Continue the remaining 2/3 of the birds on the bad diet for an additional 3 months with intravenous saline once a week as a control, intravenous essential phospholipid 200 milligrams once a week, sacrifice all at 6 months and assess disease severity. Now, 3 months of the bad diet, you fill up with plaque. 6 months of the bad diet, you fill up with plaque. 6 months of the bad diet, and then you intervene at 3 months with essential phospholipid and you're regressing. So you're not just preventing this disease from getting worse, you're actually regressing it. They're still on the bad diet. Despite the bad diet, the PPC is reversing atherosclerosis. Why? Because it's blocking the incorporation of the high cholesterol into cholesterol ester. It's breaking down the cholesterol esters such that they can be loaded up to the HDL and taken out through the liver. Here we see an aorta of the group that received placebo, intravenous saline, and the bad diet. It's full of plaque. This animal received the bad diet and PPC, and there was far less plaque. We've established that PPC prevents or regresses experimental atherosclerosis in animals. Will PPC provide the same benefit to us humans? In this study, they looked at the effect of PPC therapy on plaque volume in humans. 15 subjects with asymptomatic early atherosclerosis. Amongst these 15 subjects, there were 57 discrete plaques visible within their carotid or femoral arteries on ultrasound examination. So you do a baseline ultrasound for plaque volume. They all take PPC 900 milligrams 3 times a day for 1 year, and then you repeat the ultrasound. That's the dose I take. The reason I take 2,700 milligrams of PPC every day is because I read all these articles. I think it's a pretty good idea. The researchers observed that the smaller plaques slowly increased in size early on, and then they stabilized. The larger plaques increased in size, and then they actively regressed. Why did they increase over the first 6 months? It may be that it takes time to turn a ship around, or it might be that certain therapies that are beneficial will slightly increase plaque volume before they regress it. Recall that PPC is mobilizing cholesterol from atheroma, so there might actually be a slight increase in plaque size before regression. Testosterone may do something like this. All the studies of testosterone replacement therapy in men with cardiovascular disease when you're using physiologic dosing with testosterone show a net benefit. But if you do CT angiographic studies with careful measurements in people with early arterial disease, there'll be a slight increase in plaque size early on, and it might be that therapies that are beneficial are altering the characteristic of the plaque so it enlarges slightly before it regresses. In any event, there is a net regression of atherosclerosis with PPC in humans, matching the findings in the animal studies. PPC improves your lipid panel. PPC leads to plaque regression. PPC improves red cell and platelet rheology. What effect will PPC have on your symptoms of coronary insufficiency? Will PPC attenuate angina? This study was carried out in Russia. They took 507 subjects with symptomatic coronary insufficiency, effort-induced angina. You do baseline clinical and treadmill assessment, treat them all with 6 weeks of PPC. I think it was 900 milligrams 3 times a day, but I couldn't tell reading the Russian abstract, and then you reevaluate at 6 weeks. Angina episodes per week falls from 8 episodes at baseline to 4 episodes at 3 weeks, 2.5 episodes on average at 6 weeks. Nitroglycerin requirement likewise falls in lockstep from 7.5 to 2.5 tablets per week. Let's compare PPC versus niacin in coronary insufficiency. Now, we use niacin to lower your lipids. We use PPC to lower your lipids. Let's see how they will compare in the treatment of symptomatic coronary disease. 100 subjects with hyperlipidemia. They had coronary disease, 32 with a prior heart attack. They all had angina. Admiral bicycle stress EKG study. 4 weeks prior to study entry, they all begin a low-fat, low cholesterol diet. You stop all lipid-lowering drugs. Baseline laboratory study, stress EKG, clinical data, just as we would evaluate you clinically in the office before we would begin a treatment program, randomize these 100 subjects with symptomatic coronary disease to a 6-month program of niacin, 500 milligrams 3 times a day, or PPC, 500 milligrams per day for 2 weeks, and then 1,800 milligrams per day to follow. In Europe and Russia, if you have angina, they will treat you with daily PPC for several weeks till you get better. Then they transition you to oral therapy. Reassess patient status periodically, and this was an open protocol. The subjects knew, and the doctors knew who was getting niacin, who was getting PPC. Now, with niacin, cholesterol falls 16%, with PPC 14%. LDL falls 18% with niacin, 15% with PPC. HDL rises 21% with niacin, PPC 11%. Niacin is the most effective therapy we have regarding raising the HDL, and it worked better than did PPC. Triglycerides dropped roughly 36% in both groups. Now, the problem with niacin is flushing. You'll turn pink, you'll feel like a lobster. So in the niacin group, 14 of the subjects had side effects and 9 quit because the flushing was intolerable. There were no important side effects with PPC. 2 quit simply for logistic reasons. Conjugated dienes is a marker of LDL oxidation, a marker of oxidative stress at the level of LDL or the cell membrane. And conjugated dienes fell with both therapies, both niacin and PPC. There was this prevention of lipid oxidation. ApoB hydroperoxides is another marker of LDL oxidation. It did not change significantly with niacin, but it changed significantly with PPC. So niacin is doing a little bit better on lowering your lipids. PPC is doing a little bit better at decreasing LDL oxidation. Stress test duration, baseline and 6 months improves a little bit. A half a minute with niacin, it improves more, nearly a minute with PPC. How much work you could do, the wattage didn't really change with niacin, it changed significantly with PPC. So treadmill time, you're doing a little bit better with the PPC therapy. Angina episodes per week falls in both groups, but you can see it falls more with PPC from 3.8 to 0.9. Angina intensity also fell. So both groups improved symptoms symptomatically. Now, I was surprised because I never thought of niacin as an anti-anginal therapy, but here it did work, but PPC worked better. PPC doesn't lower lipids as much as does niacin, but it lowers lipid oxidation better, and as we know, it does a very good job of removing plaque from the artery wall and improving the ability of red cells to navigate the capillaries, so we would expect that PPC would work better than niacin in improving treadmill time and decreasing symptoms, and indeed that is what we saw here. Now, they looked at the characteristics of the HDL particles. Now, the nomenclature here is a little bit difficult. It's different from what we use in the United States, but here you're looking at the change in the characteristics of the HDL, and 2B increased and 2A and 3A decreased. Now, the ones that decreased were the HDLs that were not loaded up with cholesterol. But because the PPC stimulates LCAT to esterify cholesterol with linoleic acid and load up the HDL, the 2B portion increases. It shows that HDL function was improved and it was doing a better job as a taxi to take cholesterol out of the artery wall. So PPC versus niacin in coronary insufficiency, similar lipid lowering effect. Niacin actually is a little bit better. PPC has a better antioxidant effect, better effect on stress test parameters, superior clinical efficacy, and it was side effect free as opposed to niacin, which often does cause side effects. PPC in experimental atherosclerosis, we're going to take male and female Wistar rats and expose them to different experimental conditions. The control group gets a standard diet. The atherogenic group receives a diet which is 2% cholesterol, 40% hydrogenated fat, so that's trans fats, and a drug called PPU, propylthiouracil, to make them hypothyroid. And if you're hypothyroid, you have hyperlipidemia, and you're more likely to deposit that cholesterol into the artery wall. Then a third group gets PPC administered via nasogastric tube, 280, 900, or 2800 milligrams per gram per day. So we're going to divide these rats into experimental groups. Group 1 gets the atherogenic diet for 60 days, then they go on the standard diet. The second group gets the atherogenic diet plus PPC for 60 days. So will PPC prevent diet-induced atherosclerosis over 60 days? Group 3 gets the bad diet for 60 days, then you switch to a normal diet and treat them with PPC. Will PPC, in combination with a standard diet, ameliorate atherosclerosis due to 60 days of the bad diet? Group 4 is the control standard diet for 120 days. Now, here's on the standard diet, so the stippling in the darkness would refer to atherosclerotic plaque. The standard diet, there's no atherosclerotic plaque. If you're on the bad diet for 60 days, this is male, this is female rats, you can see that there's atherosclerotic plaque. The bad diet for 60 days, and then you switch to a good diet, there's going to be some regression of plaque because you went from a bad diet to a good diet. That would make sense. The bad diet plus low-dose PPC for 60 days, there's less plaque than with bad diet alone. With the higher doses of PPC, the atherosclerosis brought out by the bad diet for 60 days is prevented. So if you're on the bad diet and you take high-dose PPC, the PPC is pulling lipids out of the artery wall quicker than they're entering the artery wall on the basis of the bad diet. You do not get atherosclerosis. So here we look at bad diet for 60 days, then go to the standard diet plus PPC, and the pre-existent plaque almost is gone. If you're on the bad diet for 60 days, then go to a good diet with higher dose of PPC, there's a total resolution of atherosclerosis. So diet-induced atherosclerosis, this animal model, was prevented with PPC, and it was regressed with PPC. This is the aorta of an animal fed the atherogenic diet without PPC for 30 days. This animal was on the atherogenic diet for 60 days, then switched over to the standard diet and treated with high-dose PPC. And while these are black and white slides, you can see that the aorta of the animal on the poor diet is loaded up with atherosclerotic plaque. Then that animal would be treated with PPC and go on the good diet, and you can see there's far less plaque within the aorta. In this animal model, PPC regressed diet-induced atherosclerosis. This is certainly a busy slide, but it supports the concept that PPC supplementation leads to lipid exchange. When we take PPC, we are replacing unhealthful saturated fatty acids with healthful unsaturated fatty acids in the serum, in the liver, in the aorta, and within every cell of the body. Blue refers to the standard diet, red to the atherogenic diet, green is the poor diet with PPC, purple is the bad diet initially, then you switch over to a controlled diet, and then you treat with PPC. In the serum and in the liver and the aorta, within the phospholipids, triglycerides, and cholesterol esters, on the bad diet, we see a greater representation of saturated fatty acids, conversely, a lower representation of unsaturated fatty acids in phospholipids, triglycerides, and cholesterol esters. Within the artery wall, with PPC supplementation, there's a greater representation of unsaturated versus saturated fatty acids within cholesterol esters. Cholesterol esterified to saturated fatty acids or oleic acid is going to get stuck within atheroma. Cholesterol esterified with unsaturated fatty acids is on its way out. PPC blunts the esterification of cholesterol with oleic acid. It promotes dissolution of that bond, freeing up cholesterol to be re-esterified with linoleic acid and then to be loaded up on the HDL to be removed from the artery wall. PPC promotes reverse cholesterol transport. I'd like to present two more animal models that illustrate the mechanism through which PPC lowers plaque burden and improves blood flow. Then I will summarize and present a few case studies. This evaluation involves healthy rabbits. They're placed on a 20% beef tallow diet to produce hyperlipidemia, thus their serum cholesterol was 485. and they were treated with or without intravenous PPC, 100 milligrams per kilogram IV every other day. That would be equivalent to the dose that we would use in our human patients. You'll evaluate lipids and aortic plaque burden at 15 weeks and compared to rabbits on a healthy diet not treated with PPC. So if you're a healthy rabbit receiving Purina rabbit chow, your cholesterol is 114. On the hyperlipidemic diet, your cholesterol is 45. The bad diet plus PPC, cholesterol is even higher. Now, that was not a statistically significant difference, but it's showing that PPC is working not really by lowering your cholesterol, it might, but it's doing something else. And why was the cholesterol high? It could be that the PPC is producing reverse cholesterol transport and pulling cholesterol out of the vascular wall. Thus, the serum cholesterol would be greater with the bad diet plus PPC. Now, plaque burden is really what we care about, and they graded them from 1 to 4. The normal rabbits did not have plaque. They were all grade 1. Those on the high cholesterol diet, 2 had grade 4. The rest had grades 2 and 3. High cholesterol diet plus PPC, there was less atherosclerosis. None were high grade. They were all had intermediate levels of plaque formation. If we look at the amount of cholesterol in the aortic wall, in the healthy controls, there's low concentrations of cholesterol ester and free cholesterol. On the high cholesterol diet, of course, there's much more free cholesterol and cholesterol ester. With the hyperlipidemic diet plus PPC, you have less vascular wall cholesterol. So the PPC is not really lowering hyperlipidemia, but it is lessening the amount of cholesterol that deposits in the artery wall, and thus you have less atherosclerotic plaque. So there's lower plaque burden, less aortic cholesterol. Now let's look at the activity of aortic wall enzymes. So in the healthy controls, you have some phospholipase and lipase. They will break down lipids into the component materials that could be esterified with oleic acid to form vascular atherosclerosis. And you've got low levels of cholesterol-esterase. Now, on the high cholesterol diet, you're going to induce the enzymes that break lipids down into their components to allow them to be deposited in the artery wall as atheroma, and there's much less cholesterol-esterase. So you're on this bad diet, you're inducing enzymes that help you incorporate the dietary lipids into the artery wall, and you're shutting down the enzymes that would promote deesterification of vascular wall cholesterol such that you could have reverse cholesterol transport. Bad diet and PPC, the enzyme levels basically return to normal. You're less likely to break down the lipids and incorporate them in the plaque. Cholesterol esterase that breaks down vascular wall lipid is preserved. And this is basically what Dr. Rinse figured out, because he felt that the enzymes that within his biochemistry were not processing cholesterol properly, so he supplements with his version of PPC, and he doesn't really limit the cholesterol in his diet, yet he is stimulating reverse cholesterol transport, thus blood flow improved and Rinse's angina resolved. This is our part B of this study. They take these New Zealand white rabbits, 24 weeks of age, and they put them on a normal diet or the hyperlipidemic diet, and they all receive an IV infusion every other day containing saline, salt water as control, 1 milliliter of PPC for 10 weeks. Another group, they continue for 18 weeks. They're receiving saline and a lower dose of PPC for 18 weeks. Then you're going to euthanize the animals and evaluate serum cholesterol, aortic atherosclerotic plaque, the activity of the lipid processing enzymes, vascular wall free cholesterol, and cholesterol ester content. So, of course, serum cholesterol rose with the bad diet, and it was even a little bit higher with the bad diet and PPC, but the bad diet with PPC, there was less atherosclerotic plaque. Phospholipase A1 breaks this bond of phosphatidylcholine to create a lysophosphatidylcholine, that is phosphatidylcholine with 1 as opposed to 2 fatty acids. When that is present in the vascular wall, it's a signal of danger, and that will actually activate the endothelium to allow white cells to come in and perhaps engorge on LDL cholesterol that has been trapped and oxidized. So we do not want high levels of aortic wall phospholipase A1 or phospholipase A2 that breaks this bond, creating lysophosphatidylcholine. So with the bad diet, for 10 weeks, aortic wall phospholipase 1 is increased. PPC doesn't really blunt it, but if you go on for 18 weeks, you can see a progressive increase in phospholipase A1, and there's protection with phosphatidylcholine. Same situation with aortic wall phospholipase 2. It is induced with the bad diet, so you can break down lipid materials and incorporate them in the vascular wall. There's protection against the deleterious effects of the bad diet with PPC. Aortic wall lipase, that's going to break down triglycerides to diglycerides and monoglycerides so you can incorporate them into plaque, is induced with the atherogenic diet. And of course, there's blunting with PPC both in 10 weeks and at 18 weeks. Cholesterol esterase, which is going to break down atheroma, is reduced with the bad diet for 10 weeks and 18 weeks, and you can see cholesterol esterase, which is going to promote reverse cholesterol transport or initiate reverse cholesterol transport, is stimulated if you add in PPC to the atherogenic diet. And then incorporation of oleic acid into cholesterol ester, which is what we don't want to see, of course, increases with the high lipid diet, and there's protection when you add in PPC. And this is the brilliance of Jacobius Rinse. He figured this all out, and he knows that PPC will block incorporation of oleic acid into cholesterol ester and stimulate deesterification and then reverse cholesterol transport via the HDL, less than cholesterol acetyltransferase system. I'm making a case that PPC supplementation is a good idea in the prevention and treatment of cardiovascular disease. But is there any toxicity associated with PPC therapy? Many of the prescription agents that we use and the invasive procedures that we carry out, while helpful to the vast majority of patients treated, they do have downsides. There is potential toxicity. Recall that PPC is a drug in Europe and Russia. Before it was released for human use, toxicity testing was carried out in animal studies, and various animals were used, receiving high doses of oral or IV PPC, and no side effects were noted. There's no impairment in the ability of an animal to carry out a pregnancy while they're receiving PPC. So no animal model toxicity was noted. The only way you can hurt an animal with PPC is if you take the burlap bags of the soybeans, these 50 to 100 pound bags of soybeans, and throw it at the animal and crush it, you can hurt them. But otherwise, there's just no toxicity associated with PPC in animal models, and no toxicity has been associated with the use of PPC orally or IV in humans. We've covered a lot of ground. We started with the historical development of PPC in cardiovascular medicine, starting with Jacobius Rinse when I was in junior high. We discussed phospholipid and lipid nomenclature. We studied the effect of PPC on lipid metabolism, the effect of PPC on vascular wall cholesterol metabolism, vascular rheology, that's platelet and red cell function. We discussed the use of PPC admixed with EDTA in metal detoxification. We covered the effect of PPC on methyl cycle dynamics, and I presented clinical studies and case reports. Regarding the chronology of discovery, we started with Jacobius Rinse and the Rinse formula. We moved on to the utilization of PPC as a prescription agent in Europe and Russia, and it's available in the United States as a generic oral or intravenous therapy. And we covered the use of PPC admixed with EDTA to provide an oral approach to reverse cholesterol transport and chelation therapy. Clinical utilization of PPC. What options are available to you? If you're going to receive PPC intravenously, we can utilize one of three methodologies. Within the IV slow push method, we take a syringe and fill it halfway full with PPC. We puncture your vein, draw back blood, we agitate the syringe such that the PPC will bind to the cell membranes of the red cells. And then this is administered in a IV slow push. And by binding the PPC to the red cells, this is felt to ensure even distribution throughout the body. The advantage of this methodology is that it's quick. You're in and out of the office in 10 to 15 minutes. The disadvantage is that we can give you only a small amount of PPC, but we can utilize this method. If our focus is on the brain, if the issue is a neurologic disease, we will use the lipid exchange format. This is the IV slow push method, followed by intravenous glutathione and folinic acid. Glutathione is the middle linebacker of our antioxidant detox systems. Folinic acid supports the methyl cycle. The PPC will enter the brain and give off choline, which can be used to make acetylcholine, the neurotransmitter involved in memory. So if the problem is memory, neurologic function, we use the lipid exchange program, IV slow push PPC, followed by the antioxidant glutathione and the methyl cycle supporter folinic acid. The majority of our patients utilize the intravenous 90-minute slow infusion approach. Here, PP is administered over 90 minutes in a dextrose solution. We start with 500 milligrams with your first session, then go to 750 milligrams, then we go to 1,000 milligrams. We work our way up to 1,500 milligrams. Most individuals tolerate intravenous PPC well. A few individuals early on, you don't feel right due to the lipid exchange which is occurring. Thus, we start at a low dose and work our way up. In Europe, if you're symptomatic, you will receive intravenous PPC daily for 2 weeks and then switch to oral therapy. In our practice, we typically treat you with IV PPC once or twice a week. If I feel that you bear a significant heavy metal burden, I might treat you with 1 IV PPC a week and 1 EDTA a week. After a period of time, when we feel you've improved adequately, we will switch you to oral therapy utilizing the microspherical PPC EDTA preparation, either Detox Max or Lipophos EDTA. So we can start with IV therapy and then transition you to oral therapy. If you are not symptomatic, if we're not in a rush, if we're interested in a slow and steady approach to heavy metal detoxification and reverse cholesterol transport, we might use oral microencapsulated PPC admixed with EDTA. The trade names for this material are Detox Max or Lipophos EDTA. Within this methodology, the PPC is sonicated into microspheres, greatly increasing the degree to which the PPC will be absorbed. We typically treat you with 1/4 to 1/2 bottle twice a week. 1/2 bottle, 6 teaspoons, will provide 15,000 milligrams of PPC, and we feel that it is completely absorbed. This PPC will be incorporated into lipoproteins, particularly the HDL, and then into the cell membranes of every cell within your body. EDTA, lipoic acid, and magnesium hitchhike in the microspheres, greatly increasing the degree to which they are absorbed following oral administration. If we are considering treating you with oral microspherical phosphatidylcholine EDTA, of course, first I'm going to carry out a baseline assessment. We'll look at your functional status, angina frequency, how far you can walk. I'd like to carry out a single diagnostic chelation challenge to estimate your soft tissue metal burden to gauge how much metal detox do we need to achieve. I'm going to look at all of your other risk factors, look at your lipids. I'm going to look at kidney function. Now, heavy metal detoxification is a proven value in the prevention and treatment of kidney disease. However, if your kidney function is marginal and we rapidly remove from your body lead and cadmium through the kidneys, there's the potential for at least transient kidney dysfunction. So if kidney function is poor, I might start with a lower dose and then I will monitor your kidney function. And when we demonstrate that your kidney function is stable to improved, I might increase the dose. The typical dose would be a 1/2 bottle, 6 teaspoons twice a week to give you 15 grams of PPC, 75 milligrams of lipoic acid, and 500 milligrams of EDTA. And you would not take this stuff straight. It wouldn't taste very good, so you dilute it in juice and water. And it's best taken away from saturated fats because you want to flood your system with unsaturated fatty acids, not saturated fats. And there may be a possible synergy taking your Detox Max with oral safflower oil. Why is this the case? We can get back to the rinse formula, and the rinse formula was based on soybean lecithin, and soybean lecithin contains predominantly unsaturated fatty acids. But when we take in soybean lecithin or any phosphatidylcholine orally, before it's going to be absorbed in the GI tract, one fatty acid will be split off. So we're going to be absorbing phosphatidylcholine with one as opposed to two fatty acids attached to its carbon backbone. And then as soon as this material enters the bowel wall, a fatty acid in the milieu will be reattached to phosphatidylcholine. And safflower and sunflower oil are rich in linoleic acid. So Rinse took soybean lecithin along with another source of linoleic acid to increase the likelihood that the majority of the phosphatidylcholine absorbed would contain linoleic acid. So if we're going to be taking oral phosphatidylcholine either as the microspherical approach or as a gel cap, it's reasonable to take it along with safflower or sunflower oil to maximize the amount of 1,2-dilinolenyl phosphatidylcholine that will be absorbed. PPC is available orally in Europe under the trade names Lipostabile or N-Essential, or in the United States under the trade names Foscal or Plaquex. I presented a number of European studies demonstrating benefit of oral PPC in various cardiovascular disease states. The material used was oral PPC Lipostabile. If you bear a heavy plaque burden, or if you're experiencing symptoms, I will likely recommend concomitant supplementation with lumbrokinase. As you recall, lumbrokinase degrades fibrin and fibrinogen and provides direct anti-thrombotic and anti-atherosclerotic effects. Lumbrokinase synergizes nicely with PPC. You all have access to the Rinse formula. The Rinse formula is inexpensive. If you can afford to buy food in the grocery store, you can afford the Rinse formula. To receive intravenous PPC, you need to work with a physician. The Detox Max preparation of microencapsulated PPC with EDTA is available only through a licensed healthcare provider. However, on your own, you can obtain Lipofos EDTA or oral Foscol. Stated otherwise, you can get better on your own based upon your knowledge and your drive and your personal strength. We're not going to just treat you with PPC. We're going to treat you with PPC within a comprehensive, integrative approach to the prevention and treatment of atherosclerotic vascular disease. Of course, we'll start with a comprehensive baseline evaluation. What is your functional status? How far can you walk? How many episodes of chest pain do you experience every week? How often do you require nitroglycerin? If you're starting with 5 episodes of angina per week, and after a period of time, you're down to 3, then to 2 to 1 episodes of chest pain, that suggests that your physiology is improving, that plaque is regressing, that blood flow is improving. Conversely, if you're experiencing more frequent angina, that suggests that we're not improving your physiology and that we need to revisit our treatment plan. Whenever possible, I will carry out a physiological evaluation. Endothelial function refers to the ability of the artery wall to vasodilate and generate nitric oxide. Carotid IMT reflects your current predisposition to plaque formation. In response to treatment, we expect to see improvements in endothelial function and carotid IMT, and we have DVD presentations on these two methodologies. If your symptoms are pronounced, if your functional status is poor, I may recommend that you undergo a coronary angiogram or a CT angiogram. If you have severe 3-vessel coronary disease, if a large amount of heart muscle is at risk, and your symptoms are pronounced or unstable, you would likely be best served with a coronary revascularization procedure, bypass surgery, or stent. We may not have the luxury of time to turn things around by resolving all the phenomenon that are contributing to atherosclerosis. After you recover from the bypass or stent, then we can deal with these causes of heart disease in a more relaxed fashion. I will look at all of your cardiovascular risk factors and take aim at every abnormality identified, and increasingly we're carrying out genomic testing. We're finding that our patients bear down regulations, reduced function status for many of the genes involved in detoxification and in the neutralization of free radical oxidative stress. Our clinical approach, we will use drugs and nutraceutical measures as needed for symptom control to improve your functional status, to lower your anginal burden. As we're working to improve arterial blood supply, you may need revascularization, as we said, bypass surgery or stent placement. If you have a pattern of blockages not amenable to direct revascularization, we can treat you with ECP to improve endothelial function and generate a protective collateral flow. We look at your risk factors. I will recommend detoxification of metals and organic pollutants, and we'll treat you with PPC intravenously or within an oral format. There'll be a periodic reassessment of symptoms and your physiologic and functional status. I'm going to present 3 more cases and then we will summarize. IV and oral PPC and EDTA for progressive claudication at age 93. PV was a 93-year-old hypertensive woman with hyperlipidemia. Her LDL was elevated at 148. Her LPA was markedly increased at 83. Homocysteine was elevated at 15. Fibrinogen, a marker of inflammation, was elevated at 413. In October of 2005, she underwent a non-invasive vascular evaluation where we compared the blood pressure in your arm to that in your calf. It should be 1:1. PV had peripheral vascular disease. The blood pressure in her right calf was lower than that in her right arm. The ratio was 0.79. On the left, the ratio was 0.86. At that time point, she was asymptomatic. In 2006, she experienced claudication. That's angina of the calves. She would walk. There was not enough oxygen delivered to the calf muscles. They would cramp up. She needed to stop. I could barely detect pulses in her feet. We treated her with antioxidant vitamins, essential fatty acids, lysine and proline to neutralize the protein A, and she received lumbrokinase and intravenous PPC alternating with magnesium EDTA infusions, 10 of each. By October, she was walking a mile without symptoms, and we transitioned her from IV therapy to oral therapy with Detox Max, which is the microspherical PPC EDTA preparation, 1 ounce twice a week. 1 year later, all gains maintained. PV would have been a very poor candidate for revascularization surgery, so we treated her within a comprehensive format, starting with intravenous PPC and EDTA, and then transitioning her to oral therapy. CA experienced premature vein graft failure, and we treated him with ECP and concomitant PPC and EDTA therapy. CA was not a healthy man. He was 71. He was diabetic. He'd experienced a stroke, and he required prior surgery for esophageal and prostate malignancy. CA presented in September of 2001 with a heart attack involving the back wall of his heart. We call this an inferior wall myocardial infarction. Heart catheterization demonstrated multivessel coronary disease. 4 bypass grafts were placed. A little over a year later, CA returns with recurrent symptoms. A nuclear stress study was carried out suggesting multivessel recurrent coronary disease. CA had also experienced a heart attack. His ejection fraction was 32%. Normal is 50%. So he undergoes an angiogram showing severe 3-vessel coronary disease. His left intral mammary artery to left ascending graft was open. 2 vein grafts were closed. 1 vein graft had a 60% narrowing. These narrowings were not amenable to balloon angioplasty or stent placement. CA was stuck. When I met CA in March of 2003, despite maximal medical therapy, he was experiencing symptoms with minimal activity requiring 9 nitroglycerin tabs per week. So we treated CA with ECP to generate a collateral circulation, to generate natural bypasses and to improve endothelial function, along with concomitant therapy with Detox Max. And with this program, angina resolved. He could walk 3 floors without difficulty. Diabetic neuropathy resolved, and we were able to drop his long-acting nitroglycerin and ACE inhibitor, a vasodilating agent, as his BP had normalized. In a sense, PPC works with Mother Nature, exerting favorable effects on enzymes involved in lipid metabolism. The enzymes of lipolysis, vascular wall cholesterol deesterification, and reverse cholesterol transport are favorably affected. Hepatic lipase activity is stimulated, helping the liver clear lipids from the circulation. Thus, PPC will improve your serum lipid panel. Conversely, lipases and phospholipases that would break lipids down and incorporate them into the vascular wall are inhibited. Cholesterol within the vascular wall can be esterified with oleic acid to form cholesterol oleate to make up atheroma. That enzyme is inhibited by PPC. Conversely, cholesterol esterase that will break down cholesterol oleate into free cholesterol, that enzyme is stimulated, allowing it to be reesterified with linoleic acid by HDL-associated lesser than cholesterol acetyltransferase to promote reverse cholesterol transport. Cholesterol esterase is increased, LCAT activity is increased. Again, PPC helps the liver break down lipids and improve your serum lipid panel. PPC blocks the breakdown of lipids and their incorporation into the vascular wall. PPC blocks esterification of cholesterol with oleic acid to form cholesterol oleate, which makes up atheroma. PPC will stimulate the breakdown of cholesterol oleate into free cholesterol, which is then reesterified with linoleic acid by lesser than cholesterol acetyltransferase, which is associated with HDL to pull the cholesterol out of the artery wall and return it to the liver. With PPC administered orally or IV, we expect to see an improvement in the serum lipid panel. Cholesterol, LDL, triglycerides will decrease, HDL will increase, LDL oxidation is decreased, insulin sensitivity improves, blood sugar control will improve, blood pressure may drop slightly. Cell membrane fluidity and function will increase, arteries are more elastic, platelets are less sticky, blood is less viscous, the ability of serum to dissolve a clot is enhanced, microvascular blood flow improves. Homocysteine falls, PPC provides an antioxidant effect, it lowers inflammation, prostacyclin to thromboxane ratio improves, thus you're converting essential fatty acids into vasodilating as opposed to vasoconstrictive prostaglandins. Vascular calcification may decrease. We presented a case study showing vascular decalcification in response to PPC. We may have been lucky. That's just a case report. There have been no clinical trials. This is something that we'll be watching for. If you're experiencing coronary disease, we expect to see a decrease in angina frequency and severity. You'll use fewer nitroglycerin tablets. If we care to stress test, your treadmill time will improve. Time to ST segment depression, that's the time point in which we can determine that your heart is not receiving adequate oxygen. Time to ST segment depression will improve. If you suffer from lower extremity peripheral vascular disease, your symptoms of claudication will decrease. You'll be able to walk farther. If we're doing ultrasounds of the carotid or femoral artery, plaque volume will decrease. Blood flow should improve. We've completed our discussion regarding the use of PPC in the treatment of cardiovascular disease, but we're not done yet. We're only halfway through the marathon. Part 2 of our presentation will discuss the antioxidant and anti-inflammatory effects of PPC. We'll talk about how PPC can be used to optimize cell membrane function. We'll talk about the use of PPC in upper and lower GI inflammatory conditions, how we can use PPC to protect our cells and organs from various stresses. We'll talk about the use of PPC in reperfusion injury. We'll discuss briefly the role of PPC in cancer prevention and in neurologic health, and we'll spend time talking about the use of PPC in liver disease, and I will call this section a discussion of cardiohepatology. We will talk about TMAO and at least theoretical downside of PPC supplementation, something that we can measure and attenuate. We'll discuss potential anti-aging effects of PPC that I will summarize, and I will provide references for part 1 and part 2. So our discussion of PPC, polyenylphosphatidylcholine, in cardiovascular disease and integrative medicine is now complete, and I invite you to move on to part 2 of our discussion.